The Subcommittee on Oversight and Investigations hearing will now come to order. Today, the Subcommittee on Oversight and Investigations is holding a hearing entitled, quote, "Priced Out of a Life-Saving Drug, Getting Answers on the Rising Cost of Insulin." This is the second part of a hearing examining insulin affordability and the ensuing financial and health challenges and effects on patient lives. The Chair now recognizes herself for the purposes of an opening statement. With 7.5 million Americans relying on insulin, this problem that we're addressing today has affected countless lives. That's why this committee is determined to find answers and to find solutions. As the committee is well aware, despite the fact that insulin has been around now for almost 100 years, it has become outrageously expensive. For instance, the price of insulin has doubled since 2012, after nearly tripling in the past 10 years. We've all heard stories of what happens when patients can't afford their insulin. People have to forego paying their bills, or ration their doses, or skip doses altogether. I had a listening session in my district a couple of weeks ago, and there was a woman who came named Sierra. Sierra's been struggling for over a year and a half to pay for her insulin. Even after rationing her insulin, she's still paying over $700 a month. It's simply unacceptable that anyone in this country cannot access the very drug that their lives depend on, all because of the price of insulin has gotten out of control. As the co-chair of the Congressional Diabetes Caucus, this issue is personal with me. Along with co-chair Congressman Tom Reed, we examined these issues last year, and we issued a report exposing some of the underlying problems in the insulin market. We put that report into the record at last week's hearing. What we found during our investigation was a system with perverse payment incentives and a complete lack of transparency in pricing. Then last week, as I said, the subcommittee held its first hearing on this issue in the new Congress. We heard testimony from expert witnesses and patients in the diabetes space, and their message was clear. Insulin is unequivocally a life-saving drug, but because of a convoluted system, it has become more and more expensive to the point where far too many can no longer afford it, even though their very lives depend on it. We heard from Gail DeVore, who's a native of my hometown of Denver, Colorado, who lives with type 1 diabetes. Ms. DeVore described to the committee how the price of her insulin has shot up, and she has to ration her doses against the advice of her doctor. We also heard from Dr. Alvin Powers on behalf of the Endocrine Society, who testified, quote, "It is difficult to understand how a drug that has remained unchanged for almost 2 decades continues to skyrocket in price." The subcommittee also received testimony last week from Dr. William Cefalu on behalf of the American Diabetes Association. Dr. Cefalu spoke about the national survey the ADA conducted, which found that over a quarter of the people that they contacted had to make changes to their purchase of insulin due to cost, and those people had higher rates of adverse health effects. The witnesses last week had many different stories about the effects of rising insulin prices, but one consistent theme that emerged was the system is convoluted, opaque, and no longer serves the patient's best interests. The witnesses were some of the leading experts on diabetes care, and yet they couldn't point to a reasonable explanation for why these prices have gotten so high. And that's what leads us here today. We have representatives from the 3 drug companies that manufacture insulin, as well as 3 of the largest pharmacy benefit managers, or PBMs. Together, these companies are the ones that produce this drug, negotiate its price, and make decisions that have consequences for the availability and affordability of insulin for millions of Americans. I want to thank all of the representatives for coming today. I know for some of you it was you had to change schedules, you had to make some adjustments, and I appreciate it because all of your companies play a large role in the supply chain of critical drugs, and all the companies have, as you know, received a lot of criticism, but we're not interested in just finger pointing or passing the buck. We're interested in finding a solution to this problem, and that's why we put everybody here together on one panel so you can help us identify what the problem is and how we can fix it. And again, it's not my intention, I think Mr. Guthrie agrees, it's not our intention to unjustly assign blame to any one player. Instead, and what I think is that many entities share the blame for a system that has grown up. And we need a frank discussion about what's causing the increases and what we can do to bring them under control. As Ms. DeVore testified last week, quote, "The relief we need is right now, not next week, not next year. We need answers today because the price of insulin has risen too far and too many people are suffering and even risking death." Thank you all again for being here today. I urge you to be candid and forthcoming, and I'm now very pleased to recognize the ranking member, Mr. Guthrie, for 5 minutes for purposes of an open statement.
Thank you, Chair DeGette, for bringing this hearing together, and thank you all for being here. And I do echo the remarks that you just made. Last week, we held a hearing on the rising costs of insulin and heard from patients, doctors, and patient groups about the rising costs of how the rising costs of insulin has affected Americans with diabetes. More than 30 million individuals, and I have two nieces, 9.4% of the population in the United States have diabetes. In 2016, about 6.7 million Americans age 18 and older used insulin. The insulin prescribed today is different than the insulin discovered over 100 years ago, and the life expectancy of diabetics has improved dramatically. These innovations should not be underestimated, and a lot of exciting research is on the horizon. Someday soon, I hope we will have a cure for diabetes. As we discussed last week, however, the average list price of insulin nearly tripled between 2002 and 2013, making this vital drug unaffordable for too many Americans. Many argue that while list prices have been increasing, net prices have stayed relatively the same or have even gone down. This sounds great because, in theory, no one is supposed to pay the list price for insulin. However, if a patient is uninsured or underinsured, they may end up paying the list price or close to it. We've also heard that more Americans are paying the list price at the pharmacy counter for part of the year because of enrollment in high-deductible health plans has increased. We have struggled to fully understand, and I emphasize this, fully understand why list prices for medicines such as insulin have continued to rise. The prescription drug supply chain is complex and lacks transparency. We have had a lot of conversations with participants in the drug supply chain over the last 2 years to better understand how the pricing and rebating system works. We've been told that manufacturers set the list price, and therefore lowering the cost of prescription drugs is as simple as manufacturers lowering their list prices. On the other hand, we've heard that manufacturers can't simply lower their list price because the pharmacy benefit managers, or PBMs, demand larger rebates, and if the manufacturers do not provide them with these rebates, the PBMs won't put their drugs on their formularies for health insurance plans. Although they're not on the panel today, we've also heard concerns about other entities in supply chain, such as health insurance companies. And as Chair DeGette said, I'll emphasize, we're not here to point fingers at that. That's what we've heard. We want to try to get to a solution. While some may think that one party in the supply chain is solely responsible for the rising price of drugs, there are incentives to increase list prices throughout the drug supply chain. Beyond the potential for manufacturers to make more money by raising prices, a higher list price allows manufacturers to provide larger rebates to PBMs, most of whom have contracts that allow them to keep a percentage of the list price or receive fees based on the list price. Additionally, the health insurance companies decide whether to pass the rebate along to the patient at the point of sale or keep the rebate to lower premiums across the board for all beneficiaries. The current system contains many incentives for list prices to increase rather than decrease. Unfortunately, while we keep hearing assurances that net prices are staying flat or decreasing, and that almost all rebates are passed on to the health plans, we know that many patients are being disadvantaged by this system and are paying more for their insulin at the pharmacy counter. Your companies have taken steps to try to reduce out-of-pocket expenses for insulin to the patients who need them, and that is a good thing. I worry, however, that these are only short-term solutions. It is important that we collectively find a permanent solution that improves access to and affordability of medicine such as insulin. I thank our witnesses for being here today, and I will yield the remainder of my time to my friend from Indiana, Ms. Brooks.
Thank you, Ranking Member Guthrie, and thank you to the Subcommittee Chairwoman for hosting this hearing, for holding this hearing. It's continuing the important work that was started last Congress in examining the impact that rising costs of insulin has on patients struggling to afford this life-saving drug. Nearly 700,000 Hoosiers have diabetes or prediabetes, which is why I serve as the vice chair of the Congressional Diabetes Caucus, founded by Diana DeGette and Tom Reed. We've always worked in a bipartisan manner in that caucus, and I hope we continue in that same spirit today to find solutions. One of the companies here today, Eli Lilly, has been headquartered in Indianapolis for more than 100 years. They employ thousands of hardworking Hoosiers, many of whom are my constituents. And while I know that Lilly has put in place programs to subsidize the cost of insulin for some, I've read all of your written testimony, and everyone has ideas, and everyone has recommendations, and that's what we need to get to today. And so I look forward to hearing from our witnesses on their recommendations for change so that no American has to do without insulin or take less insulin than what they must have to stay alive and remain healthy. And I thank you all for being here. I yield back.
We're just waiting for the chair of the full committee and the ranking member for their opening statements. We'll just wait one moment. As soon as he's ready, the chair will recognize the ranking member of the full committee for purposes of opening statement. 5 minutes.
Thank you, Madam Chair. I appreciate your indulgence. I know we're all coming back from votes and a few things, so I'm glad you're having this important hearing today. It's really important. Last week, we heard a lot of different opinions on why the list price of insulin has increased significantly over the last decade. One of the doctors on that panel commented she believed that high list prices primarily benefit the pharmaceutical companies. Now, another doctor argued the current rebating system encourages high list prices, and as the list prices increase, intermediaries in the supply chain benefit. He argued the solution is not as easy as manufacturers simply lowering their list price and requires a broader reform across the entire supply chain. Now, all of the witnesses last week agreed that the current pricing system for insulin is actually harming many patients as they make healthcare decisions. We heard stories of individuals rationing their insulin and foregoing other necessities to make ends meet, and how this can lead to serious short and long-term health problems and hospitalizations, which I'm sure you all understand. It's critical we work toward ensuring that all diabetics have access to insulin. To do so, we need to identify and break through barriers and make it make it challenging to bringing down the cost of insulin for patients. For more than 2 years, we've been examining the various drivers of increased healthcare costs, so I'm glad that effort's continuing today. Earlier this year, as part of this work, myself and Republican leaders Guthrie and Burgess sent a letter to each of you that asked specific questions about the cost of insulin and the barriers to competition in the insulin market. We wanted to learn more about what's really going on. So I want to thank each of you for your thorough responses to our questions. They're most helpful as we work on this issue. While the discussion today is centered around the costs and the barriers that exist to reducing costs, it is important we do not forget the critical role that both of you, the drug manufacturers and the pharmacy benefit managers, PBMs, have in making sure patients have access to life-saving medicines such as insulin. Now, the insulin that's available today for diabetics would not exist without significant investments that Eli Lilly, Novo Nordisk, and Sanofi have made to develop and improve these medicines. These investments have saved the lives of many diabetics. Insulin manufacturers have also created patient assistance programs to help patients get access to affordable insulin. While there will be questions today about whether the changes in insulin over the past few decades justify how much the price for insulin, the list price for insulin, has increased over the same period, we know that manufacturers rarely receive the list price for their medicine. Likewise, PBMs provide many important services to patients and use different tools to help control costs while promoting health care. For example, in addition to numerous other programs, CVS Health created a Transform Diabetes Care program that used several cost containment and clinical strategies to help produce savings. OptumRx created a tool to improve provider visibility to lower costs. clinically equivalent alternative medicines at the point of prescribing. Just last week, Express Scripts announced a new patient assurance program that will ensure eligible people with diabetes participating in Express Scripts plans pay no more than $25 for a 30-day supply of insulin. Now, while these programs from manufacturers and PBMs are important and useful in the short term, they are only a Band-Aid. So we have to work on the long-term and comprehensive solutions. Many of the concerns we heard at last week's hearing on insulin are very similar to the issues that were discussed at our hearing examining the prescription drug supply chain over a year ago. So I appreciate hearing directly from the manufacturers and the PBMs today about your perspectives on why insulin costs are rising. But just like we heard at the hearing on drug pricing in 2017, to fully understand why the cost of insulin is increasing for many patients, we will need to hear from the other participants in the supply chain, including the distributors, health insurance plans, and pharmacists. But at the end of the day, we have to put the patient, the consumer, first in everything that we do. So I want to thank our witnesses for responding to our questions, and I want to thank you for being here today. You will contribute to our work, and that is most valuable. And unless somebody else wants the remainder of my time, Madam Chair, I would yield back.
I thank the gentleman. Chair now recognizes the chairman of the full committee, Mr. Pallone, for 5 minutes for purposes of an opening statement.
Thank you, Madam Chair. Today, the committee is holding the second of a two-part hearing on the increasing price for insulin. Millions of Americans rely on this life-saving drug, and they're directly affected by the ever-increasing prices. And people are having to make sacrifices to be able to pay for their insulin, and some are even forced to go without it, sometimes with tragic consequences. Last week, the subcommittee heard from expert witnesses in diabetes care. They provided testimony about the rising price of various insulin medications and the effects it's having on patients living with diabetes. We heard from an endocrinologist who described a complicated system that makes it difficult, if not impossible, for him to determine how much his patients will have to pay for their insulin. And we heard from patient advocates who described the hardship patients endure when they can no longer afford their medication or are forced to switch. These witnesses described a broken system where there's not enough transparency surrounding prices and not enough incentives to keep prices down. So today we have before us the companies that make these drugs, negotiate their prices, and make them available through health plans. Their actions and decisions have a profound impact on the lives of everyday Americans, and we need to hear these companies' response to the criticism we heard last week and their actions and what their actions are doing to contribute to rising prices or hopefully reduce prices. We know that companies need to make money in order to succeed, and in a normal market, price would reflect what the market can bear. The problem is the market for insulin is made up of people who can't survive without the product. So I'm concerned that the market is simply broken down, as I said. It appears there is a limited competition and little incentive to keep prices at a level that patients can afford, and perhaps there are incentives in place to keep raising prices. As a result, we're left with a drug that has been available for nearly 100 years, and yet the price tripled and then doubled in just the last couple decades. Clearly something is not right here. 3 companies currently manufacture insulin, and they're all represented at the hearing today. They not only make the drug, but they also set the list price. While most people do not end up paying this list price, uninsured patients often do, and even insured patients can be affected when the list price rises. And that's exactly what's been happening as the list price for insulin has skyrocketed in recent years, and it ripples through the entire system. We also have the pharmacy benefit managers, or PBMs, here, whose role it is to negotiate lower drug prices on behalf of the insurance plans. But there's not much transparency in these negotiations, and there are questions as to whether discounts are being passed down to the patient. When the manufacturers have been criticized for raising their prices, they have often pointed the finger at the PBMs. And when the PBMs have been questioned about their practices, they often point their finger back at the manufacturer. And so we're left with no accountability. For the millions of people who are suffering in the system, these back and forth arguments are frustrating and frankly unacceptable. Everyone seems to be coming out ahead here except the patient. And no one really should suffer because the high price of insulin puts it out of reach. So I hope that we can all learn today about why the costs of insulin are skyrocketing and the role of manufacturers and PBMs have played, and then figure out how to deal with it so we can make insulin more affordable. So unless somebody wants my time, Madam Chair, I will yield back.
I thank the gentleman. Chair asks unanimous consent that the members' written opening statements be made part of the record. Without objection, so ordered. I'd now like to introduce our first panel of witnesses for today's hearing. Mr. Mike Mason, who's the Senior Vice President, Lilly Connected Care and Insulin's Global Business Unit. Welcome. Mr. Doug Langa, is that right, Langa? Executive Vice President, North America Operations and President of Novo Nordisk, Inc. Welcome. Ms. Kathleen Tergoning, who's the Executive Vice President for External Affairs, Sanofi. Mr. Thomas Moriarty, Executive Vice President, Chief Policy and External Affairs Officer and General Counsel, CVS Health. Ms. Amy Bricker, Senior Vice President, Supply Chain of Express Scripts. And Dr. Sumit Dutta, Senior Vice President and Chief Medical Office, Optum RX. Welcome to all of you. I know you're all aware that the subcommittee is holding an investigative hearing, and when doing so has the practice of taking testimony under oath. Do any of you have objections to testifying under oath today? Let the record reflect that the witnesses have responded no. The chair then advises you that under the rules of the House and the rules of the committee, you're entitled to be accompanied by counsel. Do any of you desire to be accompanied by counsel during your testimony today? Let the record reflect that the witnesses have responded no. If you would, please raise your right hand so you may be sworn in. Do you swear that the testimony you're about to give, the truth is the truth, the whole truth, and nothing but the truth? You may be seated. Let the record reflect that the witnesses have responded affirmatively. You're now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. And now the chair will recognize our witnesses for a 5-minute summary of their written statements. In front of each of you is a microphone and a series of lights. The light will turn yellow when you have a minute left and red to indicate your time has come to an end. And I would appreciate it if you'd try to keep your opening statements within the time frame because we want to make sure that all of the members have the opportunity to ask their questions today. So we'll start with you, Mr. Mason. You're recognized for 5 minutes for purposes of an opening statement. Thank you.
Thank you. Chairwoman DeGott, Ranking Member Guthrie, Chairman Pallone, Ranking Member Walden, and other distinguished members. My name is Mike Mason. I'm the Senior Vice President for Connected Care and Insulins at Eli Lilly and Company. Thank you for the opportunity to participate in today's hearing. Thanks as well to your staff who met with us. I'm pleased to be here today to continue that conversation. Eli Lilly was founded in 1876 and today employs over 16,000 people in the United States. We are headquartered in Indianapolis. Lilly is proud to have introduced the first commercially available insulin product in 1923. For nearly a century, we have committed to helping people with diabetes live better and longer lives. We've invested billions in the discovery of new treatments, including biotech insulins Humulin, Humalog, and Basaglar. And in 2018, we announced our commitment to a research and development partnership that could eliminate the need for insulin. Lilly is also actively developing connected insulin devices that we hope will help people improve outcomes and adherence. Now, like many people who work at Lilly, I have a personal connection to the issues we discussed today. 4 of my immediate family members live with diabetes. I've seen them cope with the daily burdens of the disease, including injections before each meal. I've seen the devastating complications of diabetes in their lives, and I know firsthand that they benefit from new innovative treatments. Often our phone calls and visits turn to their diabetes. Over the years, we focus on these conversations on how they were managing their diabetes. But within the last 2 or 3 years, the conversations have changed. We now spend more and more time talking about how much they pay out of pocket for insulin. As a leader at Lilly, it's difficult for me to hear anyone in the diabetes community worry about the cost of insulin. Too many people today don't have affordable access to chronic medications. My colleagues and I have reflected on how we got here and what we can do to solve this problem in the short term and long term. For starters, we have not increased the list price of our insulin since 2017. But we recognize that the issue is more complex than list price, and it's important to focus on what people actually pay out of pocket for insulin. Most people who need insulins have either private or government insurance, that requires them to pay a low, affordable copay. But some people don't benefit from these low copays because their out-of-pocket costs are based on so-called retail or list prices, not negotiated prices or fixed copays. The people most exposed in our current system are those in the deductible phase of high-deductible health plans, those in the Medicare Part D coverage gap phase, and individuals without insurance. We know long-term solutions are necessary, but we are not waiting to address the gaps in the short term. The Lilly Diabetes Solution Center connects individuals to a suite of affordability solutions, including immediate access to savings offers for the uninsured and privately insured with no paperwork or applications. We provide automatic discounts at the pharmacy counter that cap the cost of a prescription for Lilly insulin at $95 for those in the deductible phase of high deductible plans. We recently announced the upcoming launch of a half-price version of Humalog called Insulin Lispro. With these and other meaningful solutions, we've tried to build a safety net preventing anyone from having to pay retail price for Lilly insulins. Our solutions are working to reduce out-of-pocket costs. Today, 95% of monthly Humalog prescriptions are less than $95 at the pharmacy, 90% are less than $50 a month, and 43% are zero. As Insulin Lispro launches and is added to formularies, even more people will pay less. Now, while these actions ease the burdens for most people in these coverage gap areas, they are still stopgap measures. Long-term systematic solutions are still needed. A good place to start is to consider the policy ideas suggested by CVS and their written testimony to foster the widespread adoption of $0 copays on preventative medications like insulin. We agree that this solution would save lives and money while cutting straight to the heart of the affordability issue. Also, we thank this community for its bipartisan action last week on legislation including the CREATES Act and a bill eliminating pay-for-delay tactics. Systematic change in our healthcare system will require action by all relevant stakeholders. We are ready to play our role, and we are confident that a solution is possible.
Thank you, Mr. Langer. You're recognized for 5 minutes.
Thank you. Chair DeGette, Ranking Member Guthrie, and members of the subcommittee. My name is Doug Langa. I am the Executive Vice President of North America, and I am the President of Novo Nordisk Incorporated. For over 90 years, Novo Nordisk has been dedicated to improving the lives of people with diabetes. We care deeply about the people who need our medicines, and we're troubled knowing that, for some, our products are unaffordable. For a company committed to helping people with diabetes, patients rationing insulin is just simply unacceptable. Even one patient rationing insulin is one too many. We need to do more. We all need to do more. This is why I appreciate the opportunity to take part in the dialogue here today. On the issue of affordability, we all hear a lot about list price. And I will tell you that at Novo Nordisk, we are accountable for the list prices of our medicines. We also know that list price matters to many, particularly those in a high-deductible health plan and those that are uninsured. So why can't we just lower the list price and be done? In the current system, lowering list price won't bring meaningful relief to all patients, and it may jeopardize access to the majority of patients who have insurance and are able to get our medicines through affordable copays. That's because list price is only part of the story. Once we set the list price, the current system demands that we negotiate with PBMs and insurance plans to secure a place on their formularies. Formulary access is critical because it allows many patients to get our medicines through copays at reasonable costs. The demand for rebates has increased each and every year. In 2018, rebates, discounts, and other fees accounted for 68 cents of every dollar of Novo Nordisk gross sales in the U.S. As a result, net prices of our insulin products have declined year over year since 2015. Despite the investment that we make in rebates, some patients, including those with insurance, end up paying list price or close to it at the pharmacy counter. As a manufacturer, Novo Nordisk has no control over what insured patients pay at the pharmacy counter. This is dictated by benefit design. In the last few years, we've seen more patients with benefit designs that require them to pay high out-of-pocket costs. So despite this ever-increasing rebates that we pay to get on formularies, patients don't get the full benefit of those rebates at the pharmacy counter. This needs to change. It's time for people with diabetes to benefit directly from the rebates that we pay. I take the mission of this company to help people with diabetes very seriously and personally. I lost my own father-in-law to this disease, so I do know firsthand what it does and how it affects patients and their families. When the healthcare market began to shift toward high-deductible health plans and we saw that more people were struggling to afford their medications, we took action. Back in 2016, we pledged to limit list price increases to single-digit percentages annually. We were one of the first companies to make that commitment, and we have honored it ever since. Our pricing pledge complemented other programs that we've had in place for years, with the goal of reducing patients' out-of-pocket costs. Through our nearly 2 decades-old partnership with Walmart, Novo Nordisk's high-quality human insulin is available at Walmart pharmacies for less than $25 a vial. In 2017, we partnered with CVS Health and Express Scripts to expand the $25 human insulin offerings to tens of thousands of pharmacies nationwide. Our human insulin is an FDA-approved, safe, and effective treatment for both type 1 and type 2 diabetes, and it's used by about 775,000 patients today. Since 2003, we have also provided free insulin to eligible individuals through our patient assistance program. Nearly 50,000 Americans received free insulin through this effort in 2018 alone. Today, a family of 4 making up to $103,000 a year could qualify for our patient assistance program. We also offer copay assistance on a wide variety of our insulin medicines, which last year helped hundreds of thousands of patients lower what they pay at the pharmacy counter. Although these valuable programs help many people today, we can't stop there. Patients are telling us that we need to do more, and we hear them. The challenge is that the current system is broken. Bringing relief to patients is going to require bigger, more comprehensive solutions built on cooperation between all stakeholders in the insulin supply chain. We want to be a part of those solutions. We look forward to working with all stakeholders to ensure that this life-saving medicine remains available to everyone who needs it. Thank you, and I do look forward to answering the questions today.
Thank you. Mr. Gonig, now you're recognized for 5 minutes.
Chair DeGette, Ranking Member Guthrie, and members of the subcommittee, thank you for the opportunity to appear before you today to discuss issues related to pricing, affordability, and patient access to insulins in the United States. I am Kathleen Tregoning, Executive Vice President, External Affairs at Sanofi. My goal today is to have an open, transparent discussion about how the system works, Sanofi's role in it, and how it can be improved. Patients are rightfully angry about rising out-of-pocket costs for many medicines, and we all have a responsibility to address a system that is clearly failing too many people. As a mom, I was heartbroken at hearing the testimony before this subcommittee of other parents who have not only endured the terrible challenge of facing illness, but have also struggled to afford the medications that they or their children desperately need. My own family is the beneficiary of a breakthrough in medicine. My husband, John, has FH, a genetic disorder that makes the body unable to remove LDL, or bad cholesterol, from the blood. He inherited this condition from his father, who passed away from a heart attack at 40 years of age when John was just 12 years old. Despite taking statins, watching his diet, and exercising regularly, John himself had a double bypass at the age of 36 and still couldn't get his cholesterol under control. Then came a class of drugs called PCSK9 inhibitors, an innovative treatment that helps people, like my husband, lower their bad cholesterol. I cannot overstate what this breakthrough means for him, our family, and our future, including for our 7-year-old son, Jack, who has inherited the same condition as his father and grandfather. I fully appreciate how important it is for science to continue to solve the medical challenges that impact so many families. And I recognize that those breakthroughs are meaningless if patients are not able to access or afford them. Over the last 20 years, Sanofi has been a leader in the advancement of new treatments to help people manage their diabetes. At the same time, we recognize the need to address the very real challenges of affordability. 2 years ago, Sanofi announced our progressive and industry-leading pricing principles. we made a pledge to keep list price increases at or below the U.S. National Health Expenditure projected growth rate, and we stand by this commitment. In 2018, our average aggregate list price increase in the United States was 4.6%, while the average aggregate net price, that is, the actual price paid to Sanofi, declined by 8%, the third consecutive year in which the amount we receive across all of our medicines went down. Insulin is a clear example of the growing gap between list and net prices. Take Lantus, for example, our most prescribed insulin. The net price has fallen by over 30% since 2012, and today it is lower than it was in 2006. Yet since 2012, average out-of-pocket costs for Lantus have risen approximately 60% for patients with commercial insurance and Medicare. Every actor in the system has a role to play, and Sanofi takes our responsibility very seriously. In addition to our pricing policy, we have developed assistance programs to help patients afford their Sanofi insulin, including copay assistance for commercially insured patients, including those in high-deductible health plans, and free insulin for uninsured low-income patients. Sanofi's commitment to patient affordability means that today, approximately 75% of all patients taking Sanofi insulin pay less than $50 a month. But we recognized that more needed to be done. Last year, Sanofi launched a unique program that allowed individuals exposed to high retail prices to access Sanofi insulins for $99 per vial, the lowest available cash price in the United States. Based on feedback from patients, providers, and the advocacy community, today we announced that we are expanding this program. Beginning in June, uninsured patients, regardless of income level, will be able to access any combination of the Sanofi insulin they need for $99 per month at the pharmacy counter. This transformative and first-of-its-kind program is the latest in a series of progressive and important steps Sanofi has taken to help patients afford the insulin they need. This action does not eliminate the need for broader system reform. I agree with the witnesses from last week's subcommittee hearing that holistic reforms to the system are not only needed, but overdue. Sanofi also supports a number of recommendations outlined in my written testimony, including many of the policies included in Chair DeGette's Congressional Diabetes Caucus report. Thank you for the invitation, and I look forward to answering your questions.
Thank you so much. Chair now recognizes Mr. Moriarty for 5 minutes. Thank you.
Thank you, Chairwoman DeGette, Ranking Member Guthrie, and members of the subcommittee. My name is Thomas Moriarty, and I serve as the Chief Policy and External Affairs Officer and General Counsel for CVS Health. Thank you for the opportunity to discuss ways to make healthcare more affordable, particularly for the millions of Americans with diabetes and those who are pre-diabetic. A real barrier in our country to achieving good health is cost, including the price of insulin products, which are too expensive for too many Americans. Over the last several years, list prices for insulin have increased nearly 50%. And over the last 10 years, the list price of one product, Lantus, rose by 184%. The primary challenge we face is that unlike most other drug classes, there have been no generic alternatives available, even though insulin has been on the market for more than 30 years. Despite this, CVS Health has taken a number of steps to address the impact of insulin price increases. We negotiate the best possible discounts off the manufacturer's price on behalf of the employers, unions, government programs, and beneficiaries that we serve. Our latest 2018 data indicates that we have been able to reduce the total cost of diabetes drugs, including insulin, by 1.7%, despite brand inflation in that year of 5.6%. Importantly, patient adherence has also increased. Specifically, we have replaced two very high-cost insulins, Lantus and Toujeo, with an effective, lower-cost follow-on biologic called Basaglar. By making Basaglar preferred, member out-of-pocket costs declined by over 9%. Among patients who switched to Basaglar, their A1C, or blood sugar levels, were improved by 0.43. To put this in perspective, every 1-point improvement in A1C among patients with uncontrolled diabetes is correlated with approximately $1,400 savings per year in medical costs for each patient. This is a real-life example of how competition works. Despite these efforts, We know this is not enough. Let me share a story about a company and their experience with diabetes. This company saw the human toll on their colleagues and continued to see escalating costs. In response, the company began offering employees and their families $0 copays for insulin, providing coverage for diabetes medications even before their deductibles were met. That means there are no out-of-pocket costs, so employees are more likely to take their medications, improve their health, and achieve lower costs. That company is CVS Health. And when something works for us, we offer these solutions to our clients. We also offer a number of tools for patients to help reduce their out-of-pocket costs and provide transparency at the doctor's office, at the pharmacy counter, and directly to the patient. For Caremark members, when they are in the doctor's office getting a prescription, we provide their doctors with real-time information about what is covered under their insurance and if there are effective, lower-cost therapeutic alternatives available. We also provide this information directly to patients online or on their phone. For CVS Pharmacy customers, regardless of their PBM or health plan, the RX Savings Finder tool enables our pharmacists to work with patients to find the most affordable medications that they need. Beyond these tools, a coordinated care approach to diabetes is essential. We've taken the lead with a program we call Transform Diabetes Care, which furthers our focus on providing patient care that eases the complexity of self-management, improves health, and reduces overall costs. Using connected glucometers, a high-touch engagement model, and local points of care, clinicians are better able to support specific member needs as their care requirements evolve. And finally, Madam Chairwoman, despite what we've accomplished, we know that more needs to be done. Let's bring more effective, lower-cost alternatives to market faster by ending pay-for-delay schemes. Let's foster the widespread adoption of $0 copays on preventive medications like insulin, recognizing that if we treat these diseases effectively, we can save lives and save money. And let's pass your proposal to reform Medicare to provide additional support services for patients with diabetes to manage their own care. We look forward to working with you and the committee to help accomplish our shared goals. Thank you, and I'll answer any questions that you may have.
Thank you so much, Mr. Moriarty. Now, Ms. Bricker, you're recognized for 5 minutes.
Chair DeGette, Ranking Member Guthrie, and members of the subcommittee, thank you for inviting me to testify at this hearing. My name is Amy Bricker, Senior Vice President of Supply Chain for Express Scripts. As a registered pharmacist, I began my career in the community pharmacy setting. As Senior Vice President of Supply Chain, I am now responsible for key relationships and strategic initiatives across the pharmaceutical supply chain, working directly with drug manufacturers and retail pharmacies with the objective of keeping medicine within reach for patients, including those with diabetes. Diabetes is of particular interest to me as I have witnessed the impacts of this disease personally. My younger brother, Jeff, was diagnosed with type 1 diabetes as a child. Diabetes is a life-changing diagnosis and can have devastating effects if not managed appropriately. I am passionate about ensuring patients have access to the medications they need. Today, I will provide an overview of Express Scripts' innovative approach to reduce the cost and raise the quality of care for people with diabetes and the more than 80 million Americans we serve. At Express Scripts, we negotiate lower drug prices with drug companies on behalf of our clients, generating savings that are returned to patients in the form of lower premiums and reduced out-of-pocket costs. Additional savings are provided through our clinical support services, which enable individuals to lead healthier, more productive lives. When it comes to prescription drugs, our goal is the best clinical outcome at the lowest possible cost. We offer innovative programs to help us achieve that goal, including several programs that address the cost of insulin for patients. One example, our Diabetes Care Value Program, closely manages the disease state through a holistic approach that combines the highest level of clinical care, advanced analytics, and patient engagement supported by technology. The program offers remote monitoring so that our specialist team can intervene when patient blood sugars are dangerously high or low. This program resulted in a 19% reduction in drug spending for diabetes. We launched Inside RX, a cash discount program for patients that are either uninsured or faced with high coinsurance. Partnering with drug manufacturers to provide the negotiated rebate at the point of sale, resulting in average discounts of 47% for brand drugs, including an average of $150 in savings per insulin prescription. Our National Preferred Flex Formulary provides employers and health plans the flexibility to immediately add drugs to their formulary if a drug manufacturer chooses to offer a lower-priced version of a drug. Recently, Eli Lilly announced it is reducing the list price of its Humalog insulin by 50%. We are excited about their decision to lower the list price on this medication and encourage other manufacturers to do the same. Most recently, Express Scripts announced the Patient Assurance Program, which caps the out-of-pocket costs at $25 for 30-day supplies of insulin. We did this in collaboration with the manufacturers represented here today. Express Scripts remains committed to delivering personalized care to patients with diabetes and creating affordable access to their medication. As expressed in several public statements, Express Scripts welcomes lower list prices. However, list prices are exclusively controlled by manufacturers. In the absence of lower list prices, the role of negotiated rebates have become increasingly important as a drug pricing strategy. In today's system, rebates are used to reduce healthcare costs for consumers. Employers use the value of these discounts to keep benefit premiums affordable and offer workplace wellness programs, among other employee and member-focused health initiatives. Half of Express Scripts clients receive 100% of rebates negotiated on their behalf. In total, 95% of rebates, discounts, and price reductions received by Express Scripts are returned to employers, plan sponsors, and consumers. Our 2018 drug trend report showed a 4.3% decrease in spending for diabetes medications for plans enrolled in our clinical solutions. For insulin, the same plans saw a 1.5% decline in unit cost. Express Scripts achieved this result by driving competition among manufacturers while also leveraging pharmacy discounts to drive savings. Looking to the future, we continue to support efforts by Congress and the administration to use market-based solutions that put downward pressure on prescription drug prices through competition, consumer choice, and open and responsible drug pricing. In closing, we are proud of what we have done to date, and we look forward to working with the committee to improve the affordability of insulin products. Thank you for your consideration of this testimony.
Thank you. Dr. Dutta, you're now recognized for 5 minutes.
Chair DeGette, Ranking Member Guthrie, Chairman Pallone, Ranking Member Walden, and members of the subcommittee, good morning. I am Dr. Sumit Dutta, Chief Medical Officer of OptumRx, a pharmacy care services company whose dedicated employees ensure the people we serve have affordable access to the drugs they need. I'm honored to be here to discuss steps we can all take to reduce the cost of insulin. The OptumRx team includes 5,000 pharmacists and pharmacy technicians who help patients learn how to take their medications, avoid harmful drug interactions, manage their chronic conditions. Our nurses infuse life-saving drugs in patients' homes. Our efforts have helped lower overprescribing and opioids. Our diabetes management program offers personalized, patient-driven services to high-risk members to help them manage their diabetes. OptumRx's negotiated network discounts and clinical tools are reducing annual drug costs on average by $1,600 per person for our customers. Our efforts start with a clinical assessment by our Pharmacy and Therapeutics Committee comprised of independent physicians and pharmacists. They evaluate our formularies based on scientific evidence, not cost. These meetings are open and transparent to our customers. Cost only becomes a factor after this independent committee has identified clinically effective drugs in a therapeutic class. Because OptumRx promotes the use of true generics to drive costs lower through competition, about 90% of the prescription claims we administer are for generics. Unfortunately, in the case of insulin, there are no true generic alternatives. Because many branded insulin products are therapeutically equivalent, we negotiate with brand manufacturers to obtain significant discounts off list prices on behalf of our customers. Already, 76% of the people we serve who need insulin pay either nothing at the pharmacy or have a fixed copay, most commonly $35. For insulin users on high deductible or co-insurance plans, we have taken action to help them directly benefit from the savings we're negotiating with manufacturers. Last year, we dramatically increased the discounts at the pharmacy counter for millions of eligible consumers who are now seeing an average savings of $130 per eligible prescription. And the savings are even higher on insulin. Last month, we announced a decision to expand this point-of-sale discount solution to all new employer-sponsored plans beginning January 2020. Nevertheless, the price of insulin remains too high. A lack of meaningful competition allows manufacturers to set high list prices and continually increase them, which is odd for a drug that is nearly 100 years old and which has seen no significant innovation in decades. These price increases have a real impact on consumers in the form of higher out-of-pocket costs. The most impactful way to reduce insulin prices is by opening the market to true generics and biosimilars. This is why we support efforts to reform the patent system and promote true generic competition. For years, insulin manufacturers have used loopholes in the patent system to stifle competition. One manufacturer has filed 74 patents on one brand to prevent competition. Others have engaged in multi-year patent disputes to delay the introduction of lower-cost products. Congress can increase competition and lower prices by passing the CREATES Act, prohibiting pay-for-delay deals and evergreening of patents, accelerating biosimilar options, and reducing the exclusivity period for drugs. We are committed to doing our part to make insulin more affordable. I would be pleased to answer any questions you have.
Thank you, Dr. Dutta. It's now time for the members to ask questions, and the chair recognizes herself for 5 minutes. I appreciate all of your testimony. What strikes all of us on this panel is, which we've heard from all of the actors in the system, is how the list price is really high, but then there's all these workarounds that some people can get to get a lower price of insulin. And let me just give you an example. Eli Lilly increased the price of Humalog from $35 in 2001 to $275 today. Novo Nordisk increased the list of Novolog by over 350% since 2001, and on January 8th of this year, the insulin products of Novo Nordisk went up by 5%. Sanofi increased the price of Aprida from $86 in 2009 to $270 last year. And so since January 1st, the three main brands were 4.4 to 5.2% gone up this year. And most everybody here now knows my daughter Francesca, who's 25, she's a type 1 diabetic. I'm not going to put anybody on the spot, but she's on a newer kind of insulin, and she has insurance. She's still on my insurance for 8 more months, who's counting. And she renewed her prescription at the beginning of the year, and for this insulin, it says on the receipt, the retail price $1739.79. Your insurance saved you $1399.79. But for her type of insulin she's on, the list price is $347.80 per bottle. Now, she didn't pay that because she's on insurance, but she still paid quite a bit because I have a pretty high deductible. So here's the thing, is everybody's saying, well, sure, the list price is high, but there's all these workarounds. But not everybody gets the workarounds, and the question is, why is the list price so high? So I'm going to ask each one of you, and I have really limited time. So Mr. Mason, I'm wondering if you can tell me in 30 seconds how does Eli Lilly justify these huge increases in list prices in the past 10 or so years?
Thank you for that question. I hope your daughter's doing well.
Yeah, don't forget about that. Just please.
75% of our list price is paid for rebates and discounts to secure access so people have affordable
So that's what's making the price go up and up?
$210 of our vial of Humalog is paid for discounts and rebates.
Okay, Mr. Langa, same question.
So as we heard last week from Dr. Cefalo from the ADA, there's this perverse incentive and misaligned incentives and this encouragement to keep list prices high. And we've been participating in that system because the higher the rebate, the higher the list
So
price,
you
the higher
think
the
it's,
rebate.
you also think it's because the rebates, that the prices have gone up so much in the last 10 years?
There's a significant demand for rebates. We spend
Okay,
almost $18
I'm sorry,
billion.
Mr. Goning?
Yes, as part of how we set list prices, we have to look at the dynamics of the supply chain, including the rebates. We have at Sanofi limited ourselves to list price increases no greater than national health expenditures across every
Okay.
one of our products.
Okay, now, Mr. Moriarty, I bet you have a different perspective on why the list price of insulin is so high.
Chairwoman, rebates are discounts, and as we've disclosed, more than 98% of those discounts go back to our clients.
I understand, but why do you think the list prices are so high?
I can't answer that. That is the pharmaceutical manufacturer's purview.
But you don't think it's because of discounts?
I do not, no.
Ms. Bricker?
I concur. I concur. I have no idea why list prices are high, and it's not a result of rebate.
Dr. Dutta?
We see list prices rising double digits in non-rebated drugs, in generics where monopoly is lost or where manufacturers buy up and create monopoly. So we can't see a correlation just when rebates raise list prices.
Okay, so of course my time's almost up, but I think this is a good example of the problem that the members of Congress are dealing with in trying to figure out how to solve this problem, because it seems to me what's happening is that every component of the drug system is contributing to an upward pressure on the list price, and I know the members are going to have a lot of questions around that. We'll do some follow-up at the end. So I'd like to recognize the ranking member for his input.
Thank you
for
very
5
much.
minutes.
Thanks for being here, and I'm going to use a quick example just because to try to make it simple. I've been wrestling with this for about a month and trying to figure out what's happening. So if I wanted to, if Chair DeGette was making this phone and I want to buy, and she said she's willing to take $100 for it, but she says I'll sell it to you for $300, give me $200 back. I mean, that doesn't make sense. Or Chair DeGette's willing to take $100, and I say to her, hey, I'm willing to pay $100, but charge me $300, I'll give you $200 back. And the whole idea is that Brittany is the purchaser at the end, and I'm giving that to her for $100 because she's the plan, she's saving the money and passing it on to her consumers. And what we're trying to figure out is where that delta is going. It's just hard to figure out. And I've been spending a lot of time on it. So on February 6th, so the three manufacturers, I want to try to, because I got a few questions to try to go fast. You said that your list price has gone up, but your net price has gone down. What would happen if you just said, hey, I want to make my list price my net price and put it out on the marketplace? So you three.
First of all, we are dropping our list price of Humalog by 50% with our launch of Lispro insulin. For us, there is many people who have access. The vast majority of people have access for insulin at affordable costs through their health plans. That's not tied to list price.
Right.
So we don't want to disrupt those by lowering list price. And so we think the best way is to provide, in the short term, is to keep our list price at the way it is, so we don't disrupt those individuals, we don't harm the access that they have.
But if you're willing to take, I think you said you had I don't know, whatever the net price is. I know net prices are different with different plans. There's not one net price. I get it. But if you're willing to take a net price for your product, and three of you here, why wouldn't that be something out there for everyone to pay? I mean, that's what you're willing to charge, right?
It's just more difficult to do that, to disrupt that for a product that's on the marketplace today, because people have affordable access.
But you've had your net price, according to your testimony, go up 207%, where your list price dropped by 3%, according to the letter on February 6th on Humalog. And I think you all are similar too. I don't want to just do Lily, all of you guys as well. I mean, that's kind of, so we see the net price going up. I understand what you're saying, but we see the net price rise, and we don't know why is it doing it. Maybe there's a market reason for that, and it's benefiting consumers, but we want to know.
So in the current system today, the most important thing for us is for the most number of patients to get our brands at the most affordable prices. And in the system today, that is the current formulary positions. Just the 3 PBMs here today represent over 220 million covered lives.
Okay, you said there were perverse, okay, I'm
So
going to have time.
that's 80% of the lives. So for us to lose one of those positions, that would be a dramatic impact to patients in terms of the medicine that they're on, physicians in terms of their choice.
And your argument
and
is
there would be a
you would
business
lose
impact.
your position on the formulary if you lowered your price?
In the current system, if we eliminated all the rebates, yes.
You're shaking your head the
We believe
same
that we
way?
would be in jeopardy of losing
You said
those
there were
positions.
perverse incentives. What are the perverse incentives?
Well, we're spending almost $18 billion a year in rebates, discount, and fees. And we have people with insurance, that with diabetes, that don't get the benefit of that. So
What are the perverse incentives for that $18 billion in rebates? You said they're perverse.
they're going into the
That's
system
quote.
and they're misaligned, right? So that's, we believe that they should go back to the diabetic patient.
The issue here, Congressman, is not one of negotiation. The PBMs are very effective negotiators. It's what happens with the results of that negotiation. Those rebates are not necessarily going all the way through to patients. They're being used for other parts of the system. And we don't have visibility to how those rebates get used. Those rebates are part of how we secure formulary placement and cost sharing for the patients that are covered by those plans.
Would you say, so you say I'm willing to take X for a product, but for me to get on their formulary, I know I'm going to have to raise my list price because they don't want rebates? Is that what you're arguing?
That the rebates is how the system has evolved. The rebates are part of the negotiation to secure formulary placement and associated.
I went too long on that side because I'm not giving you, y'all talk to that, I guess. I had other questions, but I'd rather hear your responses to that.
So, as mentioned previously by my colleague to my left, of course, we're looking at the clinical attributes of a product. I know you want to get to the economics. The way we make formulary decisions is based on net price. And if every one of the manufacturers to my right wanted to reduce their list price, there would be no implication to the rebate status so long as the net price remained the same.
So on my example, if she's willing to sell for me 100 and I sell to Brittany for 100, and you're saying rebates keep the price down, but in the end, because you're selling to her at the net price, so why wouldn't the net price be? What we're trying to figure out is it seems like there's a price that's marked through the system that seems to be based on something, but there seems to be an inflation in a higher price that just seems to be caught up in the system. But where it really affects people, before, as we've talked about, when they're going to the point of sale, when they haven't hit their deductible, when they have, I know you've got these plans in place, and those are great, but we need to figure out the economics behind it. So if we need to do something here to help people out, we need to understand that. Which we have more than 5 minutes. I yield back.
Thanks. Chair recognizes Mr. Kennedy for 5 minutes.
Thank you. I want to thank the witnesses here, and I want to thank the chair and ranking member for holding this hearing. I'm going to follow up on some of the questions that have already been asked. I want to submit for the record, though, a Boston Globe piece from last November. I've done this before in other hearings about individuals, two mothers that brought ashes of their patients or ashes of their children in front of Sanofi in Boston and Cambridge back in November, trying to protest these prices. You all have, you know why we're here, you know what the challenges are. I can tell you, even from being here for a couple minutes, how frustrating it is to be on this side of the dais and watch every one of you do this. So I hope and I expect that you'll also understand that if that's the result of this hearing, that you're hearing bipartisan frustration on this. The status quo is not going to continue. It can't. We heard testimony last week from patients that were literally rationing, putting their lives on hold or taking serious risk for themselves and their children to be able to get access to medicine that was patented and sold for $1. And Sir, Mr. Mason, you began by saying about the 75% of that increase over the course of the past several years, the increase in list price goes to PBMs. The data that I have indicates that over the past, since 2002 to 2013, Endocrine Today estimated the average price went from $231 in 2002 to $736 in 2013, inflation adjusted. 75% of that is roughly $375. That means 127. 50% of that baseline price is not PBMs. So where's the other 50%? What justifies the other $127 increase?
You know, our net prices have gone down since 2019. So since 2009, we haven't taken a price increase until since 2017.
Sir, have you ever lowered a price off of your formulary?
We are launching a lower price Humalog That's 50% off.
So it took 15 years and global outcry on this to do it. What factors go into this? Have you ever lowered the price off of a formulary?
We have lowered our net price over the last 10 years.
And what factor goes into lowering that price? What evaluation do you take to lower that price?
What evaluation? You know, a decade ago, we were on formularies, all formularies. Now we're on formularies about half the formularies patients in America have are insulins because we're moving to strictly formularies. We have to provide rebates in order to provide and compete for that so people can use our insulin.
And Mr. Langa, have you ever lowered a list price?
We have not.
You
We have not.
And why not?
For two reasons, as I said, the biggest vehicle today for the most majority of patients in this
These
country,
guys.
no, it's formulary position. So that's the best way for us today to reach the most amount of patients in an affordable way. And anything that risks that is something that we have to strongly consider.
Even if
Everything's
it
on the
means-
table right now for Novo Nordisk. We
If
want
it
to be
takes
part of the
us
solution.
calling you in after people are telling us that they're rationing the lives of their children, how does this work? And
So-
look, I understand that part of this comes back on us. You guys are responding to the incentives that Congress sets and a lack of regulation, a lack of oversight to allow this to happen. But from my position at the moment, trying to figure out what levers to push and pull, we're asking what goes into the factors to set that list price. We don't get an answer. To lower a list price, it either hasn't happened or we don't know. You place the blame on the major of the hike of it to go on the PBMs, and PBMs are putting it back at you. So if you're in my position, what do we do to try to make sure that patients in this country get access to life-saving medication that was found initially, discovered for $1 and sold to a university to ensure that every person could get access to it? What do you suggest?
I suggest that we all come together to come up with solutions, get together with Congress to make sure that rationing never happens again. As I mentioned in my opening statement, one patient is too many, and as an organization that's for 90 years been committed to patients with diabetes, it's tragic, and that should never happen.
Mr. Gunning?
Congressman, no one should be rationing insulin. No
And
one
they
should-
do every day.
And we need to make those patients more aware of the programs
So what do you
that
do?
are available.
The programs, ma'am, there were people here last week that said those programs take weeks to get into, that there's not transparency on it. They can't wait 6 weeks to get an insulin shot.
Congressman, our copay assistance programs can be accessed in a matter of minutes online. And so patients with high deductible health
Do
plans,
you have any patients that don't have access to internet?
that we also have phone numbers that where patients
How long
can
does it take
call
for them to be able to access those programs? What percentage of folks do you deny?
for copay assistance and for it's literally a matter of moments for the value savings program that we announced today, the expansion.
That you announced today when you're in front of Congress?
It's an expansion of a program that we started last year, $99 for the insulin that they need in any combination at the pharmacy counter. People can get access to that. That's for uninsured patients. For those with high deductible health plans, they can access copay assistance. That's no more than a $10 copay.
I'm way over time, but for the folks that are uninsured that are paying your full list price,
For the folks that are uninsured paying
Yield
full
back.
list price, they now have access, as of June, $99 at the pharmacy counter for the insulin that they need per month.
Chair recognizes the ranking member of the full committee, Mr. Walden.
Thanks
for
again,
5
Madam
minutes.
Chair, for having this hearing. Thanks again to our witnesses for being here. Ms. Ternoni, in 2018, Sanofi launched Admelog. Now, I understand that's a follow-on biologic to Eli Lilly's Humalog. Now, according to press articles, Sanofi launched Admelog at a list price that's about 15% less than the list price for Humalog. Is that pretty close?
Yes, it's the lowest rapid-acting list-priced insulin.
Okay. Typically, when a generic medicine enters the market, we expect for the price of the generic to be less than the branded, and many patients to switch from the brand medicine to the generic medicine. You've told us, however, that Admelog is not on the formulary for any commercial plans. I believe that's correct.
No, yes, correct. It's only available through managed Medicaid.
So given that Admelog was launched at a lower list price than Humalog, what barriers are preventing patients from this alternative, and are there issues gaining formulary access for Admelog?
Congressman, we were unable to secure formulary access through rebating with Admelog. As to exactly why those decisions were made, I'd have to defer to my colleagues on the other side of the panel.
Has Sanofi faced these barriers when launching any other products?
Yes, Sanofi has brought a number of products to patients at lower prices, including Kevzara, which is a lower list price of a rheumatoid arthritis medicine, and we similarly face challenges.
Given Sanofi's experience with Admelog, do you think more follow-on biologics and biosimilars of insulin will help reduce the list price of insulin, or does the biologic market function differently than the introduction of a generic of a small molecule drug?
There is already competition in the insulin market, as I believe one of the colleagues referenced. Eli Lilly introduced a follow-on biologic version of Lantus several years ago, and so there is competition, and CVS in its testimony spoke to the fact that they were able to leverage greater rebates and negotiate through that.
Now I want to switch to Mr. Mason, and thanks again for being here. We've heard that sometimes a branded biologic manufacturer may tell pharmacy benefit managers, PBMs, and health insurance plans that they will no longer provide rebates for their branded product if the PBM or health insurance plan puts a follow-on biologic or biosimilar on the formulary. Has Eli Lilly told any PBMs or health insurance plans that it will no longer provide rebates for Humalog if the PBM or health insurance plan puts Admelog on its formulary?
No, we haven't.
All right. Ms. Tregonig, similarly, did Sanofi tell any PBMs or health insurance plans that it would stop providing rebates for Lantus if the PBM or health insurance plan put Basaglar on their formulary?
No, not
Mr. Moriarty, has a manufacturer ever said they would stop providing you rebates for a product if you put a competing product on your formulary?
Not that I'm aware of, sir.
Okay, so that's never happened. And then for Mr. Moriarty, Ms. Bricker, and Mr. Dutta, why isn't Admelog included on your formulary?
So the challenge that we have with Admelog specifically is one of net cost. And so through the mechanisms that we use today, which are rebates or discounts, it was more expensive than competing products. Manufacturers do give higher discounts for exclusive position. So I think that was your question to my counterpart here on the right.
Yeah, if each of you could answer that.
Yes. So to the extent that we have recognized one product as exclusive, other manufacturers will, that exclusive product will receive less discount if additional products are added.
So why not include both?
We'll receive less discount in the event that we do that.
Huh. So what about the others on the panel? Mr. Dutta and Mr. Moriarty? Can you speak to this?
The lowest cost product gets preferential position on our formulary. So, for example, generics, which are very low cost, have preferential position.
Okay. Mr. Moriarty?
And similarly, we drive to lowest available cost, lowest cost product. And with the example of Basaglar, we were able to move that follow-on biologic to preferred status and actually have most, if not all, patients now on that.
So we keep hearing that manufacturers should just lower their list prices, but a lower list price doesn't necessarily guarantee that a manufacturer will have access to patients or that that patient will pay a lower price at the pharmacy counter. Do you take the list price of a medicine into consideration when making formulary decisions?
We do not. We focus on the lowest available cost, the lowest net cost.
All right. Ms. Bricker?
The same, yes, lowest net cost.
Mr. Duda?
Lowest net cost, and for the member, we consider their cost by using point-of-sale discounts and in order to lower their cost out of pocket.
So I just want to follow up on the ranking member's questions for Mr. Moriarty and Dr. Dutta. Why then, if you look at generics and the lowest cost, why aren't either of your PBMs putting Admelog on these plans?
Madam Chair, we have gone with Basaglar as the follow-on biologic alternative in the preferred status for that category.
Okay.
It
Dr. Dutta?
It would cost the payer more money to do that.
Why?
Because the list price is not what the payer is paying. They're paying the net price.
Chair now recognizes Dr. Ruiz.
So thank you, Chairwoman. The rising cost of drugs is such a big problem that it has reached kitchen table family conversations across America. Those families are struggling, worried about having to decide between paying for insulin or paying their bills. There's been a lot of rhetoric today and finger-pointing in the drug pricing debate, and oftentimes the conversation is based on theoretical arguments about what will work for manufacturers or PBMs or insurance companies with little regard to what works for patients. As a doctor, I put my patients' needs above all else, and our solutions should do the same and reduce out-of-pocket costs for patients. In my district, according to the Health Assessment and Research for Communities 2016 survey, 1 out of 4 adults diagnosed with diabetes in the Coachella Valley are living below the federal poverty line. And over 10% of adults diagnosed with diabetes do not have health insurance that covers some or all of the costs of their prescription drugs. And this is not just a problem for the uninsured or underinsured either. Just this week, I heard from Tamara Smith and David Richard, 2 constituents who had to go on a specialized form of insulin that isn't covered by their insurance. That means hundreds of dollars more out of pocket every month. So reducing the list prices of drugs or increasing the number of generics does not solve the problem if these savings are not lowering out-of-pocket costs for people like Tamara and David. The CEO of Diabetes Patient Advocacy Coalition drove home this point in her testimony last week in stating, quote, somebody's making a profit and it's not the patients. So Mr. Mason from Eli Lilly, who is making a profit from these increases in insulin prices?
You know, I think, first of all, we don't want anyone not to be able to afford their insulin.
Who's making a profit with these increases in insulin prices that patients have to pay for?
Our net prices, the price that we receive, are going down.
Are you?
No.
Are you making a profit? Are the CEOs of your companies making these profits?
Our net prices, the price we receive, has gone down since 2009.
Well, somebody's making a profit. Somebody's getting richer on the backs of our patients. Mr. Langa from Novo Nordisk, what entity in this supply chain is prioritizing affordability and access of insulin for patients?
Well, we'd like to think we are. I mean, we participate in as many formulators as we can. As I've mentioned, that is critically most important. We have patient assistant programs as well as copay assistant programs.
So who's making a profit then?
Well, our nets are going down as well, but there is a small profit that comes.
Your nets, but your overall profits for the company and CEOs have been going up, haven't they?
No, our profit
The take-home pay from
profit
CEOs?
has been relatively stable.
From CEO pay hasn't gone up in the past several years.
His pay has increased, yes.
Okay. So last week, Dr. Cephalou from the American Diabetes Association noted that PBM's primary customers are the health plans and insurers, not the patients. He testified, quote, we don't know whether those transactions are actually benefiting the patient at the point of sale. Ms. Bricker from Express Scripts, does Express Scripts pass any savings on to beneficiaries? And how do we know what the difference is if there's not that transparency?
So yes, thank you for the question. For over 20 years, Express Scripts has supported point-of-sale rebates. We do have clients and plan sponsors that are.
So how do we know what the percentage of that cost savings to patients if we don't have transparency of what the savings are? Are they going to your clients' profit, or are they going to reducing out-of-pocket costs? How do we know?
So we support transparency for our plan sponsors, those that hire us. They absolutely have the ability to look at all of our rebate negotiated contracts as well as our retail contracts. We believe in transparency for patients.
So we need to look into what you say and what's actually being done with implementation, and that's what the purpose of this is for. Mr. Moriarty from CVS Health, are these barriers to passing discounts on to patients at the point of sale? And if so, what are they?
Sir, we have over 10 million lives covered in a point-of-sale rebate program today. We also, as you heard my written testimony and oral testimony, we really advocate for a zero copay for insulin and other preventive medications. The cost savings associated with adherence is significant.
Okay, I got 20 seconds. So let me ask this question directly. So what are each one of you willing to give up to make sure that every patient who needs insulin will get insulin? Mr. Mason?
We are willing to provide solutions, and we are providing solutions that close the gap that anyone paying.
What are you willing to give up?
We're willing to give up. We gave up $108 million last year.
Mr. Langa, what are you willing to give up?
Last year, we invested almost $18 billion in rebates, discounts, and fees, and we also spent $200
But yet the
in copay
prices are
assistance.
still going up, so the status quo isn't working. Ms. Tregoning, what are you willing to give up?
We are willing to contribute to solutions to allow patients to access, and that's why the program that we have that allows $99 at the pharmacy for the
Those solutions aren't working if we're seeing doubling, tripling cost of insulin, and our patients are having to ration and not afford their insulin.
net
Gentleman's
costs are
time's
going down.
expired. Chair now recognizes the gentleman from Virginia, Mr. Griffith.
Thank you, Madam Chair. Mr.
5
Mason,
minutes.
Ms. Tregoning, and Mr. Lango. We have heard that there are numerous fees and discounts in the prescription drug supply chain that are calculated based on insulin prices. According to what I have read, you all have fees with your supply chain partners that are based on a percentage of the list price of insulin. Why are they structured this way? You're up first, Mr. Mason. Let's go. Time's running.
The PBMs kind of own the paper of the contracts, and that's what we have to work on.
All right. Mr. Lango?
It's the current system.
Agreed. It's the current system.
All right. Have any of your companies tried to negotiate flat fees with your supply chain partners?
Yes, we have.
We have tried a variety of different avenues with contracting.
But you have not been successful. Why?
No, our efforts were pushed away.
I think it's because it's the current system, and again, there's demand for rebates today.
Ms. Tregoning?
Yes, again, that's the
So-
system under which we operate.
Other than just it's the system, what reasons did the other participants in the supply chain provide to justify a fee based on the list price of the medicine rather than a flat fee?
It's the current system. That's
Just the current system. Everybody agree with that? All right, because I move on. Mr. Moriarty, in the February 6th letter that we sent to CVS Health, we specifically asked CVS Health to list all the contractual terms in your existing contracts that are impacted by the list price of a medicine. CVS Health did not directly answer whether there were any fees charged by CVS that are calculated as a percentage of a list price. While reviewing the standard contract template commonly utilized between CVS Caremark and a health plan client for several lines of business that the committee received in response to a letter that we sent to CVS Health last August, we saw that there was a section in the template on disclosure of manufacturer fees that are disclosed that Caremark Part D services may also receive administrative fees from pharmaceutical companies that are based on a percentage of the list price of the medicine. It therefore appears as though CVS Health may use administrative fees that are based on a percentage of the list price of a medicine. This is correct, isn't it?
Congressman, over 98% of all the fees, rebates that we obtain across our services and 100% in Medicare go back to the plan sponsors.
That's not what your contract says. Your contract says you all can charge a 1% fee, an administrative fee, based on the price of the medicine. And the question that I have is, it doesn't cost your company any more to process a $4 drug than it does a $40,000 drug. Isn't that correct?
It represents the costs associated with that processing, sir.
Well, wouldn't it make more sense from a consumer standpoint that you came out and be more transparent, but that you came out with a flat fee and worked with these folks over here to come up with a flat fee? Because I understand in Part D on Medicare, you're just charging the 1%, but across the board, according to your information you sent us, you're charging 2% as a part of the rebate. You're getting 2% of that, and I don't know whether you're charging those folks an administrative fee or not, but wouldn't it make more sense just to have a flat fee for doing what y'all do?
If the flat fee represents what the current net pricing, the lowest pricing it is in the market, yes, we will do that.
You're willing to do a net, even if it costs your company some profit, you're willing to do a flat fee.
And here's the issue. I think what's been proposed before actually results in not lower costs, actually higher costs. If it results in lower costs, we will implement that.
I mean, because one of the problems we have is if you're not in one of the magic companies, you're paying the list price and you're not able to afford it, or you're paying the high deductible in order to get there because you haven't reached your deductible yet. And lots of people have opted for these plans, And so the consumer is having to pay that higher list price. They're not getting all those rebates all the time. And as a result of that, their net price has gone up substantially, and that's where we're hearing from our constituents who are having to pay that. And it just seems to me that it ought to be something that we all can look at. The whole system needs to be more transparent, and that you all ought to be paid for processing that prescription. Whether it's a $4 drug or a $40,000 drug, you ought to be charged a set standard fee that doesn't have the drug companies coming in here saying we're raising our list price so they can get more. By the way, how many billions of dollars, or at least hundreds of millions of dollars, is represented by that 1 or 2%?
We pass back, as I said, over 98%, and we had disclosed publicly what the retained number is.
What's the dollar number?
The total number across is $300 million.
I yield back.
Thank you. Mr. Kennedy offered an article for the record, and without objection, it shall be entered. The chair now recognizes the chairman of the full committee, Mr. Pallone, for 5 minutes.
Thank you, Madam Chair. I missed a lot of the hearing because we had other hearings and we were on the floor today with net neutrality. But I just want to say this. All I hear from my constituents, they're just totally disgusted, right? They figure, particularly for insulin, it's been around a long time. They don't even believe in a market-based system anymore. I mean, frankly, I believe in a market-based competitive system. I think that, that's what the country's all about. But what they tell me is just set the price. They'll literally say to me, you in Congress or some government agency should just set the price, and that's it. They just don't believe in a competitive model anymore. So, you keep saying the system doesn't work. Well, I guess part of what I'd like to know is why this marketplace competitive model doesn't work anymore. What has happened? So, last week the committee heard from Dr. Lipska, who's a clinician and researcher, and she said, and I quote, "Drug makers make excuses for why prices have gone up. They say it's the fault of PBMs or wholesalers or the high deductible insurance plans. But the bottom line is that drug prices are set by drug makers. The list price for insulin has gone up dramatically, and that's the price that many patients pay. That is what needs to come down. It's as simple as that." Now, many of my constituents say, very simple, set the price. Have the government set the price, not have the company set the price. But, that's not the competitive model, obviously. So let me just start. Mr. Mason, you set the list price for your insulins, not the PBMs or anyone else in the supply chain. Why are we talking about high drug prices when it's within your power to bring the list prices down? Why don't you just bring the list price down, or do you want us to set it? Because that's what my constituents say. Don't have Mr. Mason set it. You set it. Let the government set it. Why not?
Okay, so
if you're not going to do anything.
Well, we actually buy down everyone in a high deductible plan down to $95. So we're doing that today. Everyone who has on a Lilly insulin at the pharmacy, we buy every prescription down to $95. So we are reducing the list price. We're paying rebates in order to get access. And
are you willing to reduce it more?
We right now reduce, no matter how much they're, they can use multiple vials, multiple pen packs. We buy
all right.
Down to $95.
What would be the problem if the government lists the price and just brings it down, says that's what you got to charge?
Right now we have, the competition is fierce. our net prices are lower today.
So you think competition is working? The marketplace is working?
Yeah.
I don't hear that from my constituents. Mr. Lange, it's unconscionable that these essential drugs have seen dramatic price increases. Why isn't Novo Nordisk reducing its list price? Again, my constituents say, force them to do it.
Well, we do believe in a market-based system, and I would also say if we reduced our list price, we would put all of our formulary positions in jeopardy. Just here at the table, these 3 PBMs represent 220 million covered lives.
So you're going to blame the PBMs.
It's not to blame that. We want to put those lives at risk.
All right, well, so then let's get rid of the PBMs and we'll just set the price. The government will set the price. Then you have to worry about the PBMs. What do you think?
It's not what we believe in. We think a market-based approach,
I agree with
it is competitive.
I agree with you, but nobody thinks it's competitive anymore.
So if you look at our rebates in 2000, the average rebate for Novo Nordisk in 2014 was 48%. The average rebate just 4 years later in 2018 was 68%. That's 40% increase. We spent up to $18 billion last year on rebates, discounts, and fees to provide formulary access.
All right, I think you're just passing it on to the PBMs. Ms. Tregening, same questions. People being forced to ration their insulin because they can't afford it. What's stopping Sanofi from lowering its list price? Why don't we just set the price ourselves?
Congressman, unfortunately, under the current system, simply lowering list price, as I believe some of the witnesses last week attested to, might not help patients and actually could cause some patients who are on those formularies where we've secured position with rebates to lose access.
If we set the price, there'd be no PBMs anymore.
Congressman, we believe that the market-based system is very important for continued innovation. So
I agree, but you guys got to convince us that it's working and that the problem that we have is we always end up having to interfere with the market when it becomes monopolistic, when it's not working. And my constituents say it's not working. What are you doing, Pallone? It's not working.
Congressman, competition is working. The net prices are coming down. The issue we have is that the results of that negotiation are not finding their way to patients, and that's the issue that at hand. We, as Sanofi, are working with patients that are exposed to those high list costs. We are effectively, de facto, having a lower list price and covering through copay assistance or our value savings programs, but we don't control
the problem is,
out-of-pocket costs.
Madam Chair, I know my time's up, but everybody just blames, the PBMs blame the companies blame the PBMs, and our constituents say they're all no good. Just get rid of the system. And I'm reluctant to do that because I believe in a market-based system, but this is what I hear.
Thank you, Mr. Chairman. Chair now recognizes Mrs. Brooks from Indiana for 5 minutes.
Thank you, Madam Chairwoman. I think everyone's focused, and the answers all seem to be focused on the system, which I think we all are acknowledging and are very frustrated. It seems to be very broken. In the February 6th letter that we sent to the manufacturers, we heard it's become increasingly common for insurers and PBMs to only offer one insulin manufacturer's line on their formularies. And I want to ask some questions about formularies, and because it sounds like everyone in this finger pointing is having to do with formularies, and so I'm curious, why are, and not, being involved but we're all learning a lot more about this system, why is it that you might have one insulin on a formulary? Why wouldn't you want all of them to be on your formularies? And then I also have a question, because if you are, say, an employee's daughter or son and you're used to one insulin, then the company switches their insurance program, and then that child has to go to a different insulin. Why would we not offer as many options as possible? I'll start with you, Dr. Duda. If you could, why do we make this change? And then the rebates get in the middle of it, and the discounts, and can you just help us with, the system seems really broken, and it sounds like that's part of it.
So thank you for the question. The first assessment is purely clinical. It is about whether a product is unique or if there are therapeutic alternatives. So when you have a unique product, price is high, it's put on our formulary, there's no competition. Then, as manufacturers produce more products that are therapeutically equivalent, in the case of insulins, rapid-acting insulins, long-acting insulins in a category, then there's an opportunity, when they're equivalent, to negotiate price down off of list price. However, to your specific question, if there is a patient that requires a medication that is not our preferred product or not formulary, we offer a process for the patient and their doctor to request and provide rationale for their product. And if there's a good reason, like an allergy or something like that, then they would be allowed to have that product.
Thank you. Ms. Bricker, what would happen in the market for you to stop, for you, not just your company, but all of the PBMs here, what would happen if you stopped excluding certain insulin products from formularies? If you allowed all of them in the different categories of insulins, as I understand, if you allowed all of them to compete and be on each of your formularies?
Yes, thank you for the question. We don't have one formulary. We have many, many, many formularies. The formulary that provides the greatest savings for our clients actually limits, through exclusivity or through exclusive placement, insulin options. We do that because we're able to secure the deepest discount from the manufacturer once we award that placement. And so they're offering discount in exchange for market share, in exchange for access. But to your point, we have other options, and we believe that choice to our plans is critical, and they absolutely can select formularies that have all insulin on the formulary.
And what if we removed exclusivity from formularies?
Prices would go up.
And why do you believe prices would go up? Mr. Moriarty, why would prices go up if all of the companies were able to be a part of your formulary? Mr. Moriarty?
Because the drug companies would not offer the discounts that currently exist in the system.
And so if we were to remove all exclusivity from formularies, Mr. Mason.
You know, our rebates went up during the period where we moved from kind of dual access to exclusive formularies. That's what caused those prices to go up.
Mr. Langa.
Our rebates have been competitive for years. Year over year over year, they're competitive, and we believe in choice for the physician and choice for the patient. Someone that a physician should be able to use their clinical experience to make decisions, not a formulary.
What if we got rid of rebates and discounts, Ms. Tregoning?
We would support moving to a system in which you had fixed fees for PBMs and that we removed rebates. As long as patient access and affordability could be guaranteed, we would be more than happy to move to that system.
And do you think if we had systems like that, you all would lower your insulin prices that would be offered?
If we could be ensured that patient access and affordability would be maintained, we would certainly be willing to lower list prices if we moved away from a rebate system.
Mr. Langa.
Yeah, we support the rebate rule, and we also support that as long as there's access and affordability, we are open to that option.
Mr. Mason.
Same answer.
Thank you. I yield back.
Chair now recognizes the gentlelady from New Hampshire, Ms. Custer, for 5 minutes.
Thank you, and thank you very much for your testimony today. And as we unravel this whole process of rebates and volume discounts and the high cost that patients and families are facing for insulin, in New Hampshire we have 121,000 granted staters. Just give or take 10% of our population actually have either type 1 or type 2 diabetes. And these are the people that I have in mind, the families that we've been hearing from. But I want to understand the frustration that the diabetic Americans come not just from the dramatic increases in the out-of-pocket costs, but the mind-numbing complexity of how the drugs are priced, and a belief that insulin manufacturers and pharmacy benefit managers may have lost focus on who they're truly meant to be working for, the patient. So that's really where we're coming from, is to try to understand as we unravel this. And you've heard some of the ideas here, which would I would imagine be a dramatic change in the way you do business, certainly from the conversations I've had with the PBMs, but also from the manufacturer's point of view. I mean, I don't think anyone really comes to this with totally clean hands, because you're chasing the profits of the quarterly earnings as well as anyone else. And I think, you know, part of what's difficult for us to understand is these are medicines that have been around for a long, long, long time without a great deal of innovation, without a change in the chemistry and the medication itself. Maybe there's been a change, I understand, in the delivery mechanism. You know, maybe there's a medical device change in having a longer lasting impact on patients, and certainly for patient convenience and patient health, that's important. But we're trying to get to the bottom of why this has gone up so much. It's one thing for us to consider that in a field of medicine that has dramatic new innovations and the R&D costs, but it's all the more complex for us to sort that out with something like insulin. So I want to get at two areas, if I could. Just Mr. Mason, what efforts would you recommend to Congress to improve price transparency for patients? You obviously have taken a stand on getting rid of rebates or those types of things, but what is it that should be happening in terms of the patient understanding the pricing?
We're open for transparency to help patients. We think the biggest issue, what we're hearing right now, we want the same thing. We're not defending the system. We're just explaining the system up here. We want reform. We want, anything that provides better access to patients. The heart of what we're hearing from patients is those in high deductible plans. About half of those high deductible plans will take the rebates that are given to them, and they use those to afford chronic or affordable care for those with chronic disease. About half of them decide to actually put that back and actually lower premiums for the general population. So what we hear and what you're probably hearing is for those individuals who are in those high deductible plans where that employer has decided to say, I'm going to pick the plan design that gives me lower premiums because they're prioritizing that, they're making that conscious plan decision, and that leaves individuals with chronic medication paying this price. That is a gap in the system right now that is leading to what we are hearing the most from diabetes patients. Now, we're providing now a stopgap measure to buy all those people down to $95, but that's a short-term fix. Long-term fixes to really be focused on what can we do for these high deductible plans so that they have affordable coverage from day one, and that decision is universal.
So you would agree that there is a discount for volume purchasing. And are you saying they fall outside, and I can ask Ms. Bricker to explain this, but, well, let me go to you, Ms. Bricker. What he's saying, how do we get to transparency for the patient, and how do we get all the patients to benefit from a mechanism that makes sense to me that you've described, which is a volume discount, essentially? That's what the rebates are.
A couple things, if I may. So we believe strongly in having real-time benefit check at the time of prescribing, that the physician has at his or her fingertips what product is covered under the formulary and what it will cost the patient. Absolutely critical to ensuring that there isn't friction at the counter. Transparency also to plan sponsors so that they fully understand the value that we've negotiated for them by way of rebates and discounts. And so, of course, we've got to continue to do more. We've, as mentioned previously, announced a program for $25 insulin for all of our commercial patients, but clearly we're still faced with challenges in the Part D benefit, and we are absolutely in support of continuing to modernize that benefit such that patients don't have caps and aren't exposed to these high list prices, essentially.
My time is up, but thank you.
Gentleman from West Virginia is now recognized for 5 minutes.
Thank you, Madam Chairman. And I apologize. I've been back at 2 other committee meetings going on, so I've missed some of your, but I heard enough of it. So, Mr. Langer, I probably would focus most of my remarks towards you on this. I was here, and so just begin from my records on a thing that we have some information that we were caught a vial of insulin in '67 cost $1. If just the CPI would up $17, but yet your Novolog is now with a list price of $237, not $17. So so many times when we have our meetings back in the district and our roundtable discussions, they talk about how people in West Virginia are probably no different than around the country, having $300 and $400 a month. I just talked with a fellow this morning that said he just wrote a check for $1,000 for his insulin in excess of his insurance. What I was hearing, not only similar dollar increases like this, but I was hearing all of you say it was caused by innovation, in part by innovation. So I'm curious, what kind of innovation have we implemented over the last few years that would cause such a drastic increase in the price of insulin? The innovation part of it. Because, I'm a strong supporter of innovation. So help me out a little bit. Why is innovation causing the increase in price?
Sure. So innovation is very important to us as an organization. We're an innovator company. And I would tell you that what's most important, I think it was mentioned earlier, is that we keep the patient in mind. Because even that word incremental, it's not incremental to patients. So when you think about going from 4 to 6 injections today to 1, if you think about being able to take a mealtime insulin at or right after you eat versus an hour to an hour and a half before, if you think about basal insulin or long-acting products today that give you the support of hypoglycemia, Maybe the best way I could describe it is we have patients that want to work for Novo Nordisk because of the mission that we're on to defeat diabetes. And we have these patients sometimes speak at our company meetings.
Just trying to understand the innovation
No,
part of
but
it.
I'm gonna, I think,
Please
get to it. So
because we have run out. I don't need someone to filibuster here on me.
it's not filibustering. It's this individual talks about what he lives with is night terror. And night terror is something called low hypoglycemia at night, and actually makes him do things that are out of what he normally does. And because he got on a product called Tresiba that reduces hypoglycemia 40%, he has not had a night tremor since.
I'm saying if it's worked prior to having the innovation, that the prices were lower. Now they're skyrocketing up to 237. Can we just stop the innovation? If it worked before, why in the last 5 years, through innovation, we've gone from $17 or $20 up? I don't want to go there because as an engineer, I believe very much in research and to do that. But if we're driving the price up, innovation is supposed to drive the price down, not up. So I'm really troubled with it. But
innovation is for today and tomorrow. I think it's important because we're innovating for the future and the future of people living with diabetes. So it's our partnerships with MIT, it's our partnerships with the University of California,
back to
San
why
Francisco.
in the past, until the last few years, that I'm sure you're innovating back in the 60s, 70s and 80s, the innovation, and it wasn't skyrocketing like it is right now. So it's just counterintuitive that why innovation is driving the price up now in the last few years. Let me go back to the list prices because we're going to run out of time. But I don't understand that. I come from the construction industry, but also in life, I need to see some examples of why we have these list prices set up for discounts. I've heard you talk about. If we don't have rising list prices for cars and appliances and construction material, why is it that pharmaceuticals are jazzing up the list price so they can offer discounts? Why is that unique to the pharmaceutical field?
Again, I know you've heard a lot about this today, but it is about these misaligned incentives in the system. The higher the rebate, the higher the list price, the higher the rebate.
Yes.
And the rebates are used within the system. And that is, and again, and those rebates don't get passed through to the people living with diabetes. And that is that lies the challenge.
Should we eliminate or discourage the rebates?
Well, certainly we're supportive of the rebate rule, and we're supportive of the pass-through of those rebates to benefit patients, and we think that would be something that would be healthy for patients.
Okay, I've run out of time. I'm sorry. I yield back.
Chair now recognizes gentlelady from Florida for 5 minutes.
Well, thank you, Chair DeGette, for holding this hearing to tackle the skyrocketing insulin prices. I recently met with a family from back home in Tampa. 9-year-old Brooke and her father, Todd, explained to me how she was diagnosed when she was 3 days old in the hospital and how they've struggled with her diabetes since then. But it's not just, the big struggle hasn't really been on the health side. It's been with affording insulin and drugs. They've had to change their lifestyle a little bit, and Todd told me at one point they had run out of insulin 2 weeks before the end of the month and had to borrow a vial from an adult friend of ours who was using Humalog and had numerous vials stockpiled. And that's how, he said, that's how we do it now. We tell our endocrinologist that we use more insulin than we need in a month, so she writes prescriptions for slightly more than we use. Since the vials are good for 2 years, we have extra in case anything happens. At the end of the day, we count ourselves blessed that both my wife and I work and our insurance sufficiently helps pay for all of Brooke's type 1 diabetes supplies, but the beginning of the year is still very difficult until we pay our deductibles, and we choose to pay more for our insurance out of pocket to make those deductibles. But he says, I cannot fathom how a family can choose to limit or ration insulin for their children. The system needs to be fixed. And then I asked Brooke, I said, what would you, as a 9-year-old having to deal with this, what would you want me to ask? She says, why do we have laws that protect kids' safety, like bike helmets, seat belts, and indoor smoking bans, but not laws that would allow them to get the medicines they need to stay alive. So things have got to change. So let's start with manufacturers' list prices and how we get them under control. It seems to be that just about everyone in the supply chain except the patient is benefiting from increasing list prices. Mr. Mason, if rebates and fees tied to list price were to be restricted or eliminated, do we have any guarantee from Eli Lilly that prices would go down and patients would pay less?
We would definitely consider it.
And Mr. Langa?
Yeah, we would consider that, yes.
Is there a guarantee?
What's important to us, again, is that the majority of patients can have access at affordable pricing, and as long as there was that in place, then yes, we would consider that.
Ms. Tregoning?
Yes, as long as we can assure patient access and affordability on formularies, then we would certainly lower list price with the elimination of rebates.
Okay, there's another hitch in the system here, and that's kind of the gaming of charitable contributions. It's been reported that some manufacturers use the patient assistance programs to reduce their own tax burden, that by donating drugs to these patient assistance programs, the company is able to deduct the value of donated drugs from its taxes. In 2015, I understand Lilly donated $408 million worth of drugs to the Lilly Cares Foundation. Mr. Mason, should manufacturers be able to benefit financially from the patient assistance programs?
We do it only to help patients. We don't want anyone not to afford.
But boy, that's a big $408 million. Then I would think we would see some commensurate reduction of the list price that would be tied to that.
Our net prices are going down, and then what you're not seeing is we spent $108 million last year on savings offers that helped 525,000 people. Those aren't a tax write-up.
I think there's an issue here, though, with these kind of charitable contributions. You seem to be benefiting on both sides, and patients aren't. So, but turning to the PBMs, Ms. Bricker, if fees paid to PBMs and wholesalers are standardized and entirely delinked from the list price, what impact would it have on what the patient ultimately pays?
Over 50% of our clients receive all fees that are collected from manufacturers, and 95% of all fees and discounts and rebates are passed on to our plan sponsors. And so ultimately, when you delink the fee from the list price, there really is nothing that prevents the manufacturer from continuing to increase the price.
So, Mr. Dutta, the mission of PBMs is to get the lowest price possible for drugs for their clients, but that clearly isn't happening. How can we change the system to better align out-of-pocket patient costs to negotiated net cost instead of the list prices?
Well, 76% of our members today either pay $0 copay or most commonly a flat copay of $35. And for that other percentage that you're asking about that are on a coinsurance or a high deductible plan, we advocate for point-of-sale rebates as well as preventative drug lists such that insulins would not apply to the deductible.
I yield back my time. Thank you.
Thank you. Chair now recognizes Mr. Mullen for 5 minutes.
Thank you, Madam Chair, and thanks for holding this meeting. It's not too often we get together and actually agree on issues, but we're all talking about the same thing, and we're all scratching our head trying to figure out how we got to this point. Real quick, I want to go back to what was just asked about your guys' tax advantage for taking the rebates. Is there a tax advantage for y'all's companies for those rebates? A yes or no?
No.
No?
No.
No.
What about the charitable contributions? Is that not a tax advantage?
We only give insulin.
Well, I mean, if it's at $300, and I'm just using generic numbers. If the list price is $300, you put your rebates in, you get it all the way down to $100. Who absorbs those rebates?
That's not why we're doing it.
No. Who absorbs those rebates?
Those rebates.
Who absorbs those rebates? Do you guys absorb those rebates? If you're giving the rebates, and if the list is at $300, you're giving it to $100. Who absorbs those rebates?
The rebates go to the PBMs with whom we.
It doesn't go to the patient, though.
That's
right.
Based on that's the concern that we have.
And so, do you write that off as a charitable contribution?
That's different than a charitable contribution. The free drug program, which are run through patient assistance programs, that's different. That's providing free drug to patients below a certain income threshold. That's separate from rebate.
Going to what Mr. Griffin asked back here in the back, the innovation. I'm sorry, McCleanly asked about the innovation. When you're talking about the innovation side of things, are you using insulin today to help pay for future drugs? Is that the innovation that you guys are using for research? Does the price of insulin help offset the cost of research for future drugs?
Revenues from all of our business in part go back to fund research and development across all our areas. For diabetes in the United States, I would point out.
But I can understand price. A lot of you guys come over and you talk to my office. You talk to me in my office, and you say, "Look, the price of the drug is so we can recoup our cost to develop it." That was the cost. That's why they set it where it is, because we're trying to recoup the cost of it. And I totally get that. You got to recoup the cost, especially when you start having patents that's going to run out, and you need to recoup your cost in time. But the cost is already recouped in this. So you are using insulin today, the cost of insulin today, to pay for future drugs that are outside of insulin. Is that correct?
We continue to invest in research.
That's why you're seeing it go up so much.
No, because our revenues from diabetes are going down. The net prices are going down. Our revenues.
But you don't have any costs associated with it because it's already been developed. It's already been paid for.
But again, the revenues for Sanofi's diabetes business in the U.S. have gone down by half over the last 4 years because net prices have gone down so dramatically.
I have some quick questions I need to get to. If a patient qualifies for your all's programs, how much does it cost? How much does their insulin cost at that point?
Patient assistance, it's free.
For copay assistance, they'll pay no more than a $10 copay.
Okay.
If they qualify for the charitable, then it is free drug.
Okay.
Patient assistance is free.
It's free. With Ms. Brooker, with the Express Scripts, you guys came up with no more than a $25 charge to customers. You just rolled that out recently, right? How long did it take you to develop that?
We've been working on it for a few months.
For a few months? As the companies here on the panel, have they agreed to participate in that with you?
Yes, they have.
So it took you 2 months to come up with that. How are you guys able to offer that?
In collaboration with the manufacturers as well as in collaboration with the plan sponsors.
When a patient qualifies for y'all's programs, how long do they typically stay on those patient assistant programs? Either one.
It varies. It varies really by patient program. So they have renewal periods, but it could be 1 year, 3 years.
Do you know what average the patient stays on the program?
I'd have to get back to you on the average. I don't know what that is.
I don't have that information.
Mason?
Our separate foundation does that, so we don't have that data.
Okay. I'll yield back. Thank you so much for your time.
Thank you. The chair now recognizes gentleman from New York, Congressman Tonko.
Thank you, Madam Chairwoman. I'd like to begin by asking our panel a number of simple yes or no questions. During our hearing last week, patient advocate Gail DeVore testified that against her doctor's orders, she had rationed and diluted a bottle of insulin because she couldn't afford to pay the $346.99 it cost her per month. Are you aware of stories like Gail's? And we'll start with you, Mr. Mason, and go across with yes or no. Are you aware?
Yes.
Yes, we are.
Yes, we're aware.
Yes.
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 Have any of you personally ever had to ration a vial of insulin?
I have not.
I have not personally.
No, I have not.
I have not.
I have not.
No, and no one should.
Similarly, I hear stories from my constituents frequently about the struggle to afford life-saving medications, including having to make tough choices about putting food on the table or simply buying medication. Have any of you ever personally had to choose between feeding your family or buying a life-sustaining medication? Why don't we start with you, Dr. Dutta, and go the opposite way?
No, and no American should.
No, I have not.
I have not.
No, I have not, and agree, no one should.
I have not, and no one should.
I have not, and no one should.
In a broader sense, have any of you ever struggled to afford a medication that was recommended to you by your doctor?
I have not.
There once was a time when one of my children had to be on a growth hormone product, and we were not able to get reimbursement. At that time, it was going to be several $1,000s, and that was going to be a challenge for us. So yes, there was a time in my life.
Thank you.
I'm fortunate not to have faced that situation.
I have not.
I have not personally, but yes, my family members have struggled.
No, I have not, and no one should.
Well, I thank you for your candor. I want to be clear that I'm not asking these questions as a gotcha moment, but as a reminder that we need to approach this issue with empathy and compassion. We never know what the person next to us might be going through. These stories we've all heard and are sharing today are from real people. Modern medicines like insulin save lives. But when we dangle these life-sustaining medications just out of reach from those who need them, we are engaging in a most cruel form of torture. According to Dr. Lipska's testimony last week, 1 in 4 individuals reported using less insulin than prescribed over the past year, specifically because of cost. Let's put ourselves in their shoes for the day. We can get bogged down here in Washington with the blame game and talk about esoteric issues like rebates and list prices and patient assistant programs. But the reality is that when I go this weekend back to my hometown, to Amsterdam, New York, there will be people in my community that are in the hospital putting their lives at risk because they are so desperate for this medication that they are priced out of, that they deliberately let their blood sugar crash just so they can get free samples of insulin on their way out of the door. Regardless of where you pin the blame, the system as it exists now is horrendously broken, and the companies represented at the witness table are benefiting while patients across the country are losing. That is unacceptable, and we need answers. So last week, in testimony before the committee, we heard from the Endocrine Society that in 2017, expenditures for insulin in the United States reached some $15 billion. They also told us that 3 of the top 10 medication costs were for a type of insulin. Where is all this money going? And let's start with you, Mr. Mason.
You know, our net prices are going down. Why we hear so much of why people can't afford their insulin today, it's those individuals in about half the high deductible plans that don't benefit from the rebates and have high out-of-pocket costs because the rebates are being used to pay down premiums.
Do those net prices need to go down further?
Our net prices are going down.
No, you said they are, but do they need to go down further? In order for people to, we hear about CEOs getting an increase in their salary, and we tell us, well, the response is our net prices are going down. Do they need to go down further, or do we need to take from the CEO?
All I'm saying is our net prices are going down. The price that plans pay, payers pay to get insulin is going down, but those costs are not being used to help people who have diabetes in about half the high deductible plans. Those rebates are used in order to pay down premiums for the general population, leaving those with chronic medications like insulin exposed to the deductible. That's what we're hearing. That's the point that we need to focus on solutions. That's the gap in the current system. The current system's not working. We agree 100%. That is the heart of the issue.
Well, I say my time is up. I'll yield back. But again, a crisis that we need to resolve as soon as possible, quickly here. Thank you, and I yield back.
Chair now recognizes the gentlelady from New York, Ms. Clark, for 5 minutes.
Thank you very much, Madam Chair, and I thank our ranking member. This is a very important hearing today, and wanted to ask a couple of questions. We've heard a number of examples of the dramatic rise of insulin prices this afternoon, but I'm still not clear on the flow chart. You know, we've heard a whole lot of different things about net pricing, list pricing, and that net pricing is going down. Is that what you're saying, Mr. Mason? And okay, now, is that subject to ebbs and flows? In other words, if you're saying that price is going down as we sit here, is there a point where that price gets settled at a lower price? Or is there the possibility that it rises again? Is it like oil?
No, it's not like oil. I mean, this has been pretty flat over the last 10 years. We can provide I think we provided the data as part of our written testimony.
Well, how is it then, if they're going down over the past 10 years, that it's still unaffordable? That's the flow chart I'm talking about. If you're going down, first of all, it spiked for some strange reason. I guess the change in the system or the modernization of the system that included this rebate, shenanigan, because that's what it is at the end of the day. If you have a 100-year-old product that increased in value because all of these other dynamics got involved, and it's the same product. So can you give me a sense of what happens when you produce this product, what the cost is, and then how it gets to the point where the average American can't afford, who needs it, can't afford to access it? That's the crux of this for I think the listening public, because we've talked about a lot of terms of art here. But Americans need to know how you got to where you are, given what we know. Can you explain, or is there anyone on the panel that can explain it in layperson's terms?
Congresswoman, the insulins of today are very different from the insulins of the past. So I think that's also very important to keep in mind, that the insulins today.
We understand that.
Okay,
We
so
understand that.
In terms of the list versus net prices, the net prices have been going down steadily. We talked about our insulins. Our list price has gone down 25% over the last 5 years, or since 2012, and that is expected to continue. The issue here is that savings.
What precipitated that?
It's additional competition and rebates.
You sure it wasn't the outcry of the public that could no longer afford it, that are watering down their insulin?
Unfortunately, Congresswoman, the lower net prices are not finding their way to patients. Exactly to your point, that the rebates that exist in the system, that gap between the list and the net prices, is being used to subsidize other parts of the system. And so, unfortunately, patients.
So the system became far more complex over time. Is that what you're?
I think the system became complex, and rebates generated through negotiations with PBMs are being used to finance other parts of the healthcare system, and not to lower prices for patients.
If we extract rebates from the system, what happens?
If we move to a system of fixed fee, we support the rebate rule, then we would be able to lower our list prices, but we'd need to ensure that the formulary position.
No. I just want to know if we remove the rebates. Ms. Bricker, I think you had.
If you remove the rebates, the discounts, there is no one that's advocating then for the patient and the plan sponsor to drive discounts and affordability. So rebates are discounts. They sound mysterious. It's just a discount, and it's a volume discount.
Right.
And so PBMs serve a critical function in ensuring affordability. Are there people that slip through the cracks? Absolutely. And we're absolutely committed to figuring out how to serve each and every patient. But I would caution doing away with rebates will only increase costs.
Okay.
We support having rebates pass through to the patients who use the drugs upon which the rebates have been negotiated. That's the.
This is a circular issue, because you want that passed on to the patient,
yes,
so that you can continue to push up the price.
We don't receive list price. We receive the net price. We don't receive the list price.
Mm-hmm. You don't receive the list
No,
price.
the price that is paid to manufacturers is ultimately the net price.
Right.
So the
So-
rebates now are being used to offset other costs in the system, and what Sanofi would advocate for is ensuring that those rebates are provided to patients who are using the drugs upon which those rebates are negotiated to lower their out-of-pocket costs.
So are you saying that the PBM's demand for increased rebates is the reason you are forced to keep raising your list prices?
It is one component of how we consider, and at Sanofi we have limited our list price increases, but one component of that decision-making is the dynamics of the supply chain.
And what are the other components?
The other components include the need to continue to invest in R&D and the competitive environment.
I yield back. I think it's more P&G. That's profit and greed. I yield back, Madam Chair.
Chair now recognizes a gentleman from Maryland, Mr. Sarbanes, for 5 minutes.
Thank you. Is the rebate, Ms. Bricker, Is the rebate system transparent right now, would you say?
The rebate system is 100% transparent to the plan sponsors and customers that we service. So the people that hire us, employers of America, the government, health plans, what we negotiate for them is transparent to them.
So that we can track the list price, then we can see the rebate, then we can see the net price, then we can see the savings that you pass along to the consumer. That's all completely transparent to the public.
It's not transparent to the public unless they are our patient.
Mm-hmm.
So we
Should it be?
We don't believe so.
Should it be trade secret? Is that the problem? Like proprietary?
The reason I'm able to get the discounts that I can from the manufacturer is because
It's a secret.
Because it's confidential.
Yeah, because it's a secret. What about if we made it completely transparent? Who would be for that?
We would support transparency along the entire chain. That's the important thing, is if we have transparency all along, from the list price all the way through to patients.
Do you all support that?
Absolutely not.
No,
Because
you can't, because then it'll end up hurting the consumer.
it will hurt the consumer.
Yeah, it'll hurt the consumer to have transparency.
It will hurt the consumer, Congressman, because prices will
buy
be
it.
held high.
I'm not buying it. I think a system has been built that allows for gaming to go on. And you've all got your talking points. Ms. Trigoning, you have said you want to guarantee patient access and affordability at least 10 times, which is great. But there's a collaboration going on here. I know there's this going on too, but the system is working for both of you at the expense of the patient. Now, I reserve most of my frustration for the moment in this setting for the PBMs, because I think the lack of transparency is allowing for a lot of manipulation. I think the rebate system is totally screwed up, that without transparency, there's opportunity for a lot of hocus pocus to go on with the rebates, because the list price ends up being unreal in certain ways, except to the extent that it leaves certain patients holding the bag. Then the rebate is negotiated, but we don't know exactly what happens when the rebate is exchanged in terms of who ultimately benefits from that. And I think we need more transparency. And I do not buy the argument that the patient is going to be worse off, the consumer is going to be worse off if we have absolute transparency. I think, just to get the lobbyists in the room to shudder a little bit, I think the PBM should be utilities. Or converted to nonprofits or something. I know when you started out, I understand what the mission was originally of the PBMs. It's a complicated industry. You need an intermediary to assemble all the information on both sides, to weigh in, to assemble the bargaining position so that you can get the best price. And in the early days, that was a good argument. But now things have gotten out of control. You're too big, and the lack of transparency allows you to manipulate the system at the expense of the patient. So I don't buy the argument that the patient and consumer is going to get hurt if we have absolute transparency. And if we can't get it from a for-profit entity like the PBM, then we ought to look at other ways of doing it, including having the government get into this space and compete in providing that important function. And with that, I'll yield back my time.
Chair now recognizes the gentlelady from Illinois, Ms. Schakowsky, for 5 minutes.
Thank you, Madam Chair, for holding this hearing. I don't know if I have any questions at all, but I want to tell you something. In the 2018 election, the #1 concern of Americans, the high cost of prescription drugs. We have the names of people who have died because they couldn't get their insulin. A young man who was trying to control it himself after going off his parents' policy, dead. We know that a huge number of people are not taking the insulin that they need because they can't afford it. So then they get sick, they get sicker, and maybe they die because of it. I don't know how you people sleep at night. Between 1996 and now, when you've got Eli Lilly from $21 a vial to $275, you heard Mr. McKinley, am I saying that right? Who went through all that. Interesting, by the way. So for Eli Lilly, it's now $275. For Sanofi, it's $270. For Novo Nordisk, it's $280. Curiously close in price, and way too high. I want to tell you something that will not stand in this Congress. I heard Ms. Brooks say the system is broken. And I think on both sides of the aisle, there is a commitment. And we've even heard the President of the United States talk about price gouging. Yes, we need transparency. I have a strong transparency bill that is going to hold you guys accountable and make you notify how you justify raising those prices. You talked about another, Mr. Lenga, you talked about another drug that you're developing and that somehow that's an excuse because it helps diabetics. And that's the research and development that you do. You're in trouble. And the lobbyists out here, or maybe that's you, need to understand that this is a commitment on the part of the Congress to get drug prices, particularly life-saving, life necessities, to get those prices under control. And if you think you can, just out-talk us without any transparency, without any accountability, I just want you to know your days are numbered. When Mr. Azar became became the Secretary of Health and Human Services, I wanted to remind him that he came from Eli Lilly at the very time that those drug prices, those insulin prices went through the roof. And we are seeing that on drugs that have been like yours on the market for decades. And if you want to try and explain, I totally agree. Isn't that a good thing that now people may be able to take one vial and not have to shoot up all the time because they, and the delivery system. But we have no clue if that means that you can raise those prices 1,000%. And you think you can get away with that kind of secrecy or just blaming the PBMs. I'm not holding them unaccountable here. We need to do that. But don't excuse yourselves from this. And don't tell us about the wonderful charity prices that you give, and then you do get tax breaks, I'm assuming. Contradict me if I'm wrong. When you give charity care to people, I believe that that is a tax deductible kind of item for you. I'm not hearing anybody contradict that. I resent that very much, because then everybody else is still paying those very, very high prices. So just know something is going to happen here if you don't decide in your own interest to lower those prices so people don't have to die. And I yield back.
The lady yields back. Gentleman from California, Mr. Peters, is recognized for 5 minutes.
Thanks. I've heard a lot of the discussion, and it's been very edifying for me. And I actually, I don't want to blame you for a system that we've set up here that encourages this bizarre incentives. The fact is that it's a system that incentivizes people to charge higher list prices so they can give rebates that give them access to customers. And you know, I'm pretty much of a believer in markets. Someone called this a free market. This is really not. I don't think that we should suggest that this is the kind of competition that's going to take care of our problems. What we have here is what economists call a market failure at best. That's when it's appropriate for government to take action in a capitalist system. I think most people agree with that. And I think that's what we're going to see. We're going to have to take out the incentive, this crazy incentive to charge higher prices so that you can get to customers. And no one knows what the real prices are. I mean, it is impossible for us to understand. We have access to all this information. This is a really, really opaque system. And so we're going to have to change that. So I appreciate the input. I don't ever suggest that companies aren't going to make money when they're allowed to do it. I just think that this is a perverse system that has to be changed so that if we want competition, we get real competition. But this system of rebates is really encouraging an anti-competitive behavior. Also, I know that I'll just express a concern. This is in the courts. But now we have companies owning PBMs and plans without any assurance of the relationship between the sister companies, the PBM and the plan. Again, I think there's a real risk of anti-competitive behavior here. So, I mean, I think you've come here and done the best job you can answering these questions. It's a system that no one should have to apologize for, but it's a system that we're going to have to change here in Congress. And I think that's what you'll see going forward. So I yield back.
Gentleman yields back. We now have several members who are not on this subcommittee, but who have been gracious enough to be here for all of the hearing, and I appreciate their attendance and their input. So I'd like to first recognize Congressman Bouchon for 5 minutes.
Thank you, Madam Chairwoman. I was a physician before I was in Congress, so these type of issues are extremely important to me. For me, it's all about people and taking care of people, making sure, especially when it's a life-sustaining drug. And I appreciate all of your input. It is a system that needs changed. I mean, and we did a hearing last Congress, and we had 8 stakeholders in the entire supply chain, and we pretty much got this, the whole time. And I get that. I'm not blaming anybody. I'm just saying I think we've developed a system over time that's is going to need changed. And I'm going to have questions for both the PBMs and the companies. And Dr. Dutta? Yeah. I understand that representatives from your company testified in front of the Senate Finance Committee yesterday. My understanding is that your company was asked questions about contracting practices and relationships with manufacturers. I'd like to just follow up on those, and then Ms. Bricker and Mr. Moriarty can comment also. Can you talk about the following? Has your company ever proposed in contract or otherwise demanded that manufacturers give advance notice of list price decrease? And remind you, everybody, we're all under oath here, and we have access to information potentially that could counteract a question answer that isn't accurate.
Yes.
Okay. And that manufacturers pay a higher fee or rebate if list prices do not increase above a certain percentage in that contract year. So, for example, if they don't increase their list price above a certain percent, that they may have to pay a higher fee or rebate for that drug?
I'm not aware of that.
Okay. And that manufacturers pay a certain rebate amount even if they decrease their list price?
I'm not.
My point is if you have a list price here and the company says we're going to go down to here and the rebate was based on the higher list price, does that amount stay the same?
I'm not aware of that.
Okay. Same questions, Ms. Bricker. Do you have contract or contractual or otherwise demanded that manufacturers give advance notice of list price decrease?
No, we welcome lower list prices.
Okay, great. And the manufacturers pay a higher fee or rebate if list prices do not increase above a certain percentage in that contract year?
No.
Okay. And the manufacturers pay a certain rebate even if they decrease their list?
No.
Okay, we hear that they do, but Mr. Moriarty, same thing. I mean, you have contractual relationships that otherwise demand that the manufacturers give you advance notice of decrease in the list?
No.
Okay, great. The manufacturers pay a higher fee or rebate if list prices do not increase above a certain percentage in a contract year? Okay, great. And the manufacturers pay a certain rebate amount even if they decrease the list?
No.
Okay.
We are all about net price.
Understood. I'm going to focus on the 340B program real quickly. I have been an advocate for reforming that program. Information that Novo Nordisk provided to the committee indicated that many of Novo Nordisk's insulin products are at penny pricing in the 340B program. Moreover, information Novo Nordisk provided the committee showed that for one of these insulin products at penny pricing, the number of packages provided to 340B entities increased from just over 270,000 packages in 2014 to over 735,000 packages in 2018. That's more than a 172% increase in the number of packages supplied to 340B entities. And many of the Novo Nordisk other insulin products also saw a significant increase in the number of packages sold in the 340B program during this period. Can you explain the impact that the 340B program has had on Novo Nordisk pricing in the private and commercial markets?
We have over 18,000 facilities, I believe, at this point, roughly, and it is at penny pricing, so it's literally 99.9%. And the packaging is, I believe, as you referenced it, so it has been going up. Is the question its influence on the commercial market?
Yeah, I mean, because of that, because of its penny pricing and the volume has gone up dramatically, has that had an effect on the overall pricing structure in the rest of the marketplace, essentially?
I think the challenge has been the 340B entities and who actually gets that designation and not, and I think that's been more the complexity and the challenge than it has been the spillover.
Okay, Mr. Mason? Same thing. I mean, 340B has dramatically expanded, as we all know, right?
Similar question. I mean, obviously, it does take away our net sales. If those are legitimately helping, individuals that need that help, we're fine that our product is going.
I understand that. I mean, and quickly, I'm out of time.
Yes, I think the issue is the heavily discounted products that go into the 340B system, but are those heavily discounted prices making their way to patients?
Yeah, I'm going to just quickly say, with your indulgence, Madam Chairwoman, that in the 340B program, I firmly believe, based on this subcommittee's report that was released last Congress, that we need to seriously look at and reform the 340B program so that it continues to exist for the hospitals and patients that need it, but add a degree of transparency because it's spiraling. Thank you. I yield back.
Thank you, gentlemen. Chair now recognizes the very, very patient woman from California, Ms. Berrigan, for 5 minutes.
Thank you very much. I'm sitting here and I've been hearing this back and forth for the last couple of hours. And the way I think I would summarize this is it sounds like we're playing a middleman. It just sounds like we're playing a middleman for prescription drugs to be on a preferred list. And that's not just to put all the blame here, but then these list prices have just been skyrocketing. And then when we ask about pricing, what we're hearing back from the drug companies is, well, the net price is actually declining. Last time I checked, I think Lilly was doing pretty good. Wouldn't you say so, Mr. Mason? Why don't you tell me what the revenue was for this coming year? What's Lilly's revenue this coming year?
$21 billion.
Okay, I saw $25.3 billion for the coming year. Your CEO in 2014 was making $14.5 million in a pay package. That was in 2014. The new CEO, 2018, is making $17.2 million in a pay package. You guys are doing okay. I would think so. The American people sees that and they say, why can't we just get pricing for insulin, a life-saving drug that we need? Not that we want, but that we need. And they say Congress has to do something. And when you hear what's happening here today, that's exactly what is going to have to happen. I don't see anything happening here. I mean, look, I represent a congressional district that's a majority minority. People of color are disproportionately impacted by diabetes. Latinos, African Americans. I happen to represent a district that includes Compton and Watts, very low-income, working-class families who are struggling. And my report says there's over 80,000 uninsured there. A lot of people who probably can't afford to pay for their insulin. And do you all recognize that your pricing policies and this system is causing people to die every day? Do you all recognize that? So, Mr. Mason, do you recognize that? Let me just go down the list here. Yes or no? Do you all recognize this?
We don't want anyone not to be able to afford their insulin.
I understand that, but do you recognize that this pricing system and model is causing people to die?
We need to do something about it collectively.
Okay, that's a yes. Mr. Langut?
We recognize the model is certainly a challenge, yes.
And you're playing a role in that model. Let's not mince any words here. Is these companies and the PBMs are playing a role in this model. And that's why we're having this hearing, is because we're trying to get to the bottom of it. Ms. Trigoni.
Yes, we recognize that's happening, and that's why we put in place the programs to address the inadequacies of the current system so that that doesn't happen, so people aren't forced into rationing their insulin. We don't want to see that.
Mr. Morarty?
There's no question there's a portion of the population where this needs to be addressed very directly. No question.
Ms. Bricker?
Absolutely, there are patients falling through the cracks. We exist only to make medication more affordable.
Okay, I'm not obviously going to get you to tell me that you're part, because, I mean, and the reality is what we heard today, that's what's happening here. You know, I wish that you all would just come together and collaborate. A moment ago, Ms. Bricker, I believe you're the one who said that the way you were able to get the $25 plan and the deal that you were able to get for the insulin, that the new program you just rolled out, was that you collaborated together, that you worked together. So if you could do it there, how come you all can't do it for others, right? And so this is where Congress has to step in and do something. It's because of profits. It's because of greed. The American people are tired. And when people die, and that is what is happening, make no mistake about it, we hear about it, the country hears about it, and it's outrageous. It's completely outrageous. I want to end on just a quick on Medicare Part D. You know, in 2018, more than 43 million seniors enrolled in Part D plans. Currently, the government is prohibited from negotiating directly with the drug manufacturers on behalf of Medicare Part D enrollees. If this prohibition were lifted, the government would be able to provide the leverage needed to bring down prescription drug pricing. On a yes or no, real quick, because I only have 10 seconds, starting on the end. Yes or no, do you support Medicare being able to negotiate drug prices under Part D?
Prices are getting as better in Part D.
Yeah, yes or no, would you support the negotiating drug prices under Medicare Part D?
Still think they're needed.
Okay.
I think everything we would consider if it helped the patient.
So I said yes?
I think we consider everything. I think the fair market, the free market that's playing right now is working because we have some of the heaviest discounts in Part D.
It's not working because people are dying and they can't afford it. But next.
The PBMs are very effective negotiators. The question is, what do we do with the results of those
So
negotiations?
you don't have an answer on whether you support Medicare being able to negotiate drug prices under Part
We
D?
don't support direct negotiation because the PBMs
do
are
not.
effective negotiators.
Okay, you do not. Okay.
We do not. We
Okay.
drive very effective discounts.
Okay, Ms. Bricker?
Similarly, yes, the government.
You do not?
Do not support.
Okay. Mr. Duda?
Yeah, we do not.
Okay. I can understand why that might be the case. It's unfortunate, but my time is up. I owe back.
Thank you. I thank the gentlelady. Now, pleased to recognize the gentleman from Georgia, Mr. Carter, for 5 minutes.
Thank you, Madam Chair, and thank you for allowing me to participate in this. Ladies and gentlemen, thank you for being here today. Just full disclosure, currently I'm the only pharmacist serving in Congress. I've practiced pharmacy, community pharmacy, independent community pharmacy for over 30 years. You know, I remember, just FYI, I started when I was 10, but I can remember that I can remember when PBMs evolved. I can remember when PSC was nothing more than just a processor. That's all they did was process claims before PBMs got involved in setting up formularies. And I can remember ordering directly from drug companies and not going through a wholesaler or anyone, just getting a shipment every week, a delivery every week from Eli Lilly or any other of the companies, Upjohn or any of the number of companies that we ordered from. You know, my colleague, Mr. Tonka, mentioned earlier about patients having to make choices between eating and between paying for their medications. I've seen it firsthand. I have witnessed it firsthand. Ms. Bricker, you said you were a pharmacist and practicing community pharmacy. I don't know what your experiences were. You're obviously a lot younger than me, but at the same time, I can tell you I have seen it. I have seen patients at the counter having to make a decision between buying medicine and between buying groceries. I've seen mothers in tears because they couldn't afford their medications. I've witnessed it firsthand. I was the boots on the ground there. That's why I'm so passionate about that. I want to start with you, Mr. Langa. During a briefing with committee staff, I don't know if it was you or a member of your, or a representative of your company, but they said that list prices started to increase more rapidly around the same time that there started to be more consolidation throughout the drug pricing supply chain, and that there have been increasing demands on rebates. Has consolidation impacted the list price of medications?
I think it was a factor. I think that as the PBMs today, as I mentioned, the three here today represent almost 220 million covered lives.
And that's probably the three here today, I believe, represent over between 70 and 80% of all the PBMs in America.
Correct. So
Yes.
I think that
Okay.
as the consolidation,
All right.
that purchasing power got bigger, the rebate challenge got heavier.
Absolutely. Mr. Mason, would you agree with that? And in fact, I believe that you responded to a letter and said the same thing.
Yes.
Okay. I'd like to ask you, Mr. Moriarty, you're with CVS Help. CVS is a drugstore, right?
That's correct.
And then CareMart is the PBM. That's owned by CBS. It's the same company.
That's correct.
And then Aetna Insurance is the same company.
That's correct.
Okay, so we got Aetna, the insurance company, we got CareMart, the PBM, and we got CVS, the drugstore. All the same company, right?
That's correct.
Okay, Ms. Bricker, I believe that Express Scripts, you're here today representing the PBM.
Yes,
And you're also, you just bought out Cigna Insurance, that's right.
Cigna acquired Express Scripts.
Cigna acquired Express Scripts. And you also have your own mail order pharmacy, is that correct?
We do have a mail order pharmacy.
Okay, and Dr. Duda, same thing with you. Optum is the PBM, United Healthcare is the insurance company, and you also have your own mail order pharmacy. Is that correct?
So Optum and United Healthcare are sister companies, yes.
And you do have mail order pharmacy that you own as well?
Optum RX has a mail order pharmacy.
Yes, okay. That's a long yes answer. Nevertheless, when you've been saying during these hearings that you're returning money to the plan sponsors, can you define plan sponsors for me? Is that the insurance companies? Mr. Moriarty?
It is the employers, state, and federal.
The insurance, are you sending the money back to the insurance company?
As well as health plans, but it's much more than just health plans, yes, sir.
You're sending it back to, Ms. Bricker, you're sending it back to the insurance companies?
So we send back to the clients that hire us. Those are employers.
Do you send it back to the insurance? Please remember you're under oath here. Let's get along. Do you send it back to the insurance companies?
In the event that the plan sponsor is an insurance company, yes.
Right.
But that's
Okay.
not the
And
only
Dr. Duda, same thing with you?
In the event that the plan sponsor is...
Okay, same thing. So essentially, you're the PBM managing money, and you're sending the money back to another company that you own. In some cases, that could be the case. Isn't that right, Dr. Duda?
So we have many health plans.
I understand that, but it is possible you could be sending it back to owned by the same company. So this vertical integration that we're talking about here, that I've been on the FTC and the Department of Justice about, that's something that certainly we need to be aware of. Boy, 5 minutes flies, let me tell you. But before I relinquish my time, I want to congratulate all of you, because you've done something here today that we've been trying to do in Congress for ever since the 4 years and 3 months that I've been here, and that is to create bipartisanship. Because what you've witnessed here today is bipartisanship. This is going to end. I have witnessed it. I have seen what you have done with the PBMs. I've seen what you've done with DIR fees. I see what you're trying to do now with GER fees and BER fees. And let me tell you, what the CMS is proposing in the way of doing away with DIR fees and the way of having discounts at the point of sale, that's going to happen. We're going to make sure that happens, and that's going to bring more transparency to the system, and we're not going to stop there. Thank you, Madam Chair, and I yield back.
Thank you, Mr. Carter. I was just saying, I never thought I'd see the day when Buddy Carter was channeling Jan Schakowsky. Congratulations. I now want to recognize Mr. Guthrie for closing questions and statement.
I just want to close, and when the chair and I were discussing having the hearing, we thought insulin was a proper one to have. One, I know it's different than 100 years ago today, but we had a lady before, a doctor, physician from Yale, that said that there was held up a insulin, said it's the same insulin from 1990s as it is today, and the price has moved forward. And we wanted to because we wanted to look at the entire system, but we thought if we looked at one drug that affects almost every, like I said, I have 2 nieces with diabetes, affects almost every family, that we could look at what's going on and then we could extrapolate it to bigger. And I will tell you, and you're talking about Ms. Schakowsky, my friend Ms. Schakowsky from Illinois, she also talked about President Trump and saying that this is important to him. And my experience with him is, in meeting with him, is that drug pricing is important to him. So it's everybody. It's uniting everyone. And I'm going to be quick. I know 5 minutes went fast before I get all my questions. I'm not going to ask a question because that's not what I've been recognized for. But innovation is important. I saw a film yesterday of a father talking about his daughter, I don't know if cured's the right word, but not having any symptoms from sickle cell. I mean, it is just hepatitis C you can take with, and you talk about medical devices. You can do the artificial pancreas is here. So innovation and having a market-based system and a free enterprise system is absolutely important. But what we're trying to get at with this is, and hopefully you can see our frustration, is that we see pharmaceutical companies say our net price is going down. We see the list price going up. And I have friends here from Bardstown that are in the Buddy Carter situation or of community pharmacists, and they have described to me situations that he just described, and they have to pay the list price to sell to somebody who's not when they sell. So it's a cash flow to those kind of businesses. And what we're trying to figure out is, if the net price is the net price, then why isn't that what's paid to if the idea is we're going to get the lowest price for our insurance companies, then why isn't selling something for $135 that's cost $135 better than selling something $300 or $400 and getting $300 or $400 back, other than saying I've saved you that money? It's trying to figure out where the money's going. And so this has been informative. I think one question I want to ask that I'm going to do for the record is, so what do you put on the formulary? Is it better for a high list price with a lower net, or that's better for the insurance company, but it's not as good for if it's just a lower net price, or just a lower list price, it's actually lower for the consumer going to the counter at the pharmacy. So this is just hopefully the beginning of a series of hearings, and it's been informative, and we do appreciate your willing to come here and your testimony and trying to inform us, because we do have to make some decisions, and we don't want unintended consequences, because if you get into price controls, you get into rationing and you get into shortages, and that's not where we want to. That's not where I want to go. We want people to have a fair price if they can pay, and if they can't pay, to have the assistance to have that, because it's life-saving. So thank you for your indulgence, and I yield back.
I thank the ranking member, and I think, and I do want to thank the witnesses. I know people asked you hard questions. It was important to us to get everybody in here, and I think we can all agree that the system is broken, and it's grown up in a way over time that people didn't anticipate. But here's the thing: the people who are suffering are the patients, and in the case of insulin, the people who are suffering are people who need insulin every second of every minute of every day, or they will die. And that's the issue that we have here. And I now, having done this investigation last year with my colleague from New York, Tom Reed, and now doing this investigation, I think I've got a pretty good grip, and I think the members of this committee are getting a better and better grip of what's going on. And what's going on is a system has grown up in this country where we are continually it's a smoke and mirror system where we're continually increasing the list price of insulin in order to try to do negotiations to somehow get the price of insulin down. But let's look at the reality of the situation. The members of this panel kept saying over and over again, net prices of insulin have gone down. And one person even said that nobody pays list price, they all pay net price, but that's not exactly true. So I just want to give you the example of Humalog, because Humalog is one of those insulins. It's not 100 years old, but it's over 20 years old. And in 2001, Humalog cost $35 a vial. Today, no change to Humalog. It's not Tresiba, which, by the way, Tresiba is not an insulin. It's another drug to help absorption of insulin that's given to type 2 diabetics. So Humalog, it's still the same formulary. It's $275 today for a bottle of the same insulin that I bought for Francesca when she was 6 years old. And the generic Humalog that Lilly has come up with, good news, it's only $137 a bottle. So it's still way beyond where it was in 2001. Well, now Sanofi has a new generic alternative, Admelog. I just sat here and looked, and Admelog, it might not cost as much as Humalog, but it costs over $200 a bottle. So let's not kid ourselves that the generic equivalent of this is really any cheaper for that young woman in my district who doesn't have insurance, who's desperately trying to find 2 bottles of insulin every month. That's $400 for her, even if she bought that. So when you say nobody's paying list price, there are people paying list price. And the people who are paying list price are the people who have high deductible plans, who have to pay for the list price when they go in to the pharmacy and they're under deductible. The people who are in the donut hole of Medicare Part D, and the people who are uninsured. And I know everybody here, the PBMs and the pharmaceutical companies all have these efforts to give cheaper insulin to people like this. But I'm going to tell you, the lady I talked to in Denver, she didn't know how to get that insulin. She had no idea how to get it. And our witnesses last week said many people in that situation don't. It's not a solution to the problem. It's just a temporary Band-Aid. And it's one that we have to stop with a wholesale innovation. And let me just say finally this. It's not like the pharmaceutical companies or anybody else in the system is doing this for a public interest reason. The pharmaceutical companies had $323 billion in profits last year. The PBMs had $23 billion in profits last year. And so everybody's making a profit. And the people who are really suffering here are the people who either have to pay list price or even after their deductible have to pay an unacceptable price. And nobody here in this room wants that. So what we're going to do, we're going to get together in a bipartisan way, and we're going to work with all of you, plus everybody else in the distribution center, to figure out how we can provide insulin to diabetics at a cost that they can afford. And we are going to do that as quickly as we can. So as you heard, we're having an ongoing investigation here. We're prepared to talk to you now, and we're prepared to bring y'all back in July or in September to talk about the progress that we've made, because this is not optional and it is going to happen. So I want to thank you all again for coming today, and we're not going to have any more testimony, but I really want to thank you for coming, and I want to thank you for being part of the solution and not a continuing part of the problem. And in closing, I will remind members that pursuant to committee rules, they have 10 business days to submit additional questions for the record to be answered by witnesses who have appeared before the subcommittee. I ask that the witnesses agree to respond promptly to any such question, should you receive any, and with that, the subcommittee is adjourned.
She wouldn't answer my question. She called it wrong.